Dear members of the faculty, dear colleagues and friends, welcome to our first webinar update in neuroimaging. Given the current pandemic situation, it's with heavy heart and much regret that the organizing committee had to postpone the update in neuroimaging live conference normally this September, but we will do and go ahead for September 2021. Nevertheless, in our continued commitment to our Congress attendees, we are pleased to offer you today this free of charge online webinar. Today, more than 150 colleagues worldwide are clustered at their computer, and we are pleased that they follow us here in this dedicated webinar. Thank you all for attending this webinar. Also, thanks to the support and the gratitude of our industry sponsors, we were able to organize this online meeting. Next slide. After the lectures, there's a session with Q&A addressed to all faculty members. Please send all your questions after each lecture and in advance using the question box at your site. Next slide. Next slide, yes. Okay, we are very proud to present you our international rewarded faculty. In their field, they are rewarded authors and authors of several textbooks and papers. Moreover, they are very appreciated mentors and fellows for their residents. I wish you all, dear colleagues, a very inspiring online meeting. Next slide. I want to welcome Dr. Verbenkus from the University of Hospital of Ghent, and he will talk about spinal infections. Dear Bert, the floor is yours. Thank you.
Hello, good afternoon. Thank you, Bart, for the introduction. I would also like to thank Dr. Seijnhaven.
Thank you, Bart, for the nice introduction.
Excuses.
Thank you, Bart, for the nice introduction. I would also like to thank Dr. Patrick Seijnhaven, my former teacher and superior, and Dr. Paul Winnock de Grave for giving me the opportunity to present this case. The case is about a man of 41 years old with a migration background, and he has a medical history of a large bulbar ulcus. He presents at our department for gastroenterology for his epigastrologies that get worse postprandially, and the clinician performs a screening ultrasound. The ultrasound reveals a large hypoechoic mass that is interposed between the right kidney and the spine. We get a call for an emergent CT scan of the chest and abdomen. We have to rule out a lymphadenopathy, lymphoma, a desmoid tumor, psoas mass, or a retroperitoneal hematoma, extramedullary hematopoiesis. So the chest scan, it didn't reveal any pulmonary lesion, but when looking closely at the vertebral spine, you see an added. Putting this in the soft tissue window, you see a hypodense, well-defined mass with a rim enhancement along the spine. When looking at the coronal plane, you see a vertical extension of the hypodense mass along the vertebrae, also added psoas mass bilaterally. When looking in the bony window, there are multiple erosive bone lesions with at thoracic level 9 and 11 a breach through the facies posterior, extending into the spinal canal. The intervertebral disc spaces, however, are well preserved. The clinician performs a targeted anamnesis, which reveals a slight intermittent backache that gets worse at night. So, to revisit our differential diagnosis, we are thinking of tuberculous spondylitis. Why? Because of erosive destruction of the subchondral end plates, preservation of the intervertebral disc spaces. There are large paravertebral abscesses, and there is not much of bony sclerosis. Should also think of the procellular spondylitis. However, in this differential, the infection is more situated in the lumbar region. You see an early collapse of the intervertebral disc with a sclerotic bone reaction, and there are not much paravertebral masses in this type of infection. In pyogenic spondylitis, the infection is more situated in the lumbar region. You see an early collapse of the intervertebral disc and lots of bony sclerosis, and there are also paravertebral masses. Then there is sarcoidosis, which also causes lytic erosive bone masses and paravertebral masses, since it is a granulomatous disease, with even a destruction of the subchondral end plate possible. There is metastasis, which is mostly situated in the posterior structures, but the intervertebral disc space remains spared. As such, there is also a sparing of the subchondral end plate, and there are no paravertebral masses. You don't see a sclerotic reaction also in metastasis. Multiple myeloma presents with lots of multiple punched out lesions. You see a preservation of the subchondral end plates in the multiple myeloma. Also, the disc space is preserved, and you don't have large paravertebral masses. In lymphoma, there is a large paravertebral mass in spinal lymphoma with extension to the neural foramina into the epidural space, but there is a limited bony erosion. So, to understand better spinal infection, you have to look at the routes of dissemination in this disease. The primary route is the arterial route. Also, other important routes are the Batson's venous plexus. It's a paravertebral venous plexus that has no venous valves, which allows free fluctuations of pathogens along the spine. Normally, the primary site here is a genitourinary tract infection, and there is the contiguous route, in which there is direct spread from infection, for example, from a retropharyngeal abscess. The arterial route is the most important one. In spinal infection, the primary site that is affected is the anterolateral metaphyseal corner, because this is a richly vascularized zone. There is an exception in the pediatric spine, where the intervertebral disc is richly vascularized, so this becomes the primary site of infectious dissemination. In the early stage of disease, in the adult spine, there is a primary spread of the pathogen that is in the anterolateral corner into the intervertebral disc space, leading to infection of the adjacent subchondral end plate. There is also a spread in the early phase through the intermetaphyseal arteries to the opposing subchondral end plate. In children, the pathogen spreads from the intervertebral disc directly into the adjacent subchondral end plate, causing this configuration of infection. Further infectious spread from thereof, that depends on the pathogen and type of defense reaction. There is a pyogenic infection in which there is production of lots of pus and inflammatory cytokines. This is typical in the staphylococcal type of infection. And then there is a granulomatous type of spinal infection, in which there is a formation of large granulomas as an attempt to encapsulate the pathogen. In the vertebral type in the pyogenic type of vertebral osteomyelitis, there is in the early phase infectious spread along the subchondral end plates and a subsequent spread in the intervertebral disc space with an inflammation of the intervertebral disc. So you see a widening in the early stage, and then there is a subsequent collapse of the intervertebral disc. You see some joint effusion and the formation of large paraspinal abscesses. Then the vertebral body collapses, and you get a malalignment and kyphosis. When looking at these at radiographies, you don't see any change in up to 1 month. Then you will start to see an ill-defined subchondral end plate with some signs of destruction and a narrowed disc space. After 3 months, you will start to see some sclerotic reaction. A CT scan is much more sensitive for the early phases where you see an early swelling of the paraspinal soft tissue. And also you see an early enhancement of the intervertebral disc. You can also see collections in the paraspinal tissue, psoas muscle, and epidural abscesses. The MR is, of course, modality of choice. It allows you to see early subchondral edema in the end plate as a reaction to the infection in the anterolateral corner. You also see the earliest changes in the paraspinal tissue that present hyperintense signals. There's also the modality of diffusion weighted imaging that helps you distinguish between acute and chronic stages of disease. And an important feature in discerning non-infectious from infectious pathology in the very early phase is the imaging psoas sign. Here you see the lumbar spine, and you see some subchondral edema and an hyperintense intervertebral disc. It has the appearance of early disc degeneration, but when looking in the axial window, in the axial plane, you see there's also an hyperintense signal in the psoas muscles. So this is highly suggestive for an infectious spondylodisitis. The explanation, that's because the musculus psoas major has its origin at the anterolateral sides of the vertebral bodies, which allows an early transition of the pathogen into the muscle, causing an hyperintense signal. Looking back to our case, we don't see an intervertebral disc collapse, we don't see any sclerotic bone reaction, but we see lots of erosive bone lesions and also large paravertebral masses and psoas masses. So what's next? We performed an ultrasound-guided biopsy of the psoas mass, which revealed a chronic granulomatous inflammation with necrosis. When performing acid-fast staining, this revealed red-enhancing rods without zip, which are typical for Mycobacterium tuberculum. So this patient has tuberculous spondylitis, also called Pott's disease. It's named after Sir Percival Pott, who described severe kyphosis in his patients, which were mostly young infants and young children in the 18th century. The actual discovery, however, of Mycobacterium was in the 19th century. Tuberculous spondylitis, or Pott's disease, it's a granulomatous infection of the spine, which is an immune reaction trying to encapsulate the Mycobacterium. It has immune cells, B cells and T cells and natural killer cells at the periphery, and centrally there are necrotic Langhans multinucleated cells in which the Mycobacterium tuberculum resides in a dormant state. Mostly, tuberculous spondylitis is disseminated infection from pulmonary or genitourinary primary. Tuberculous spondylodisitis, the risk factors are poverty, overcrowding, illiteracy, malnutrition, alcoholism, drug abuse, diabetes mellitus, immunosuppressive treatment, and HIV. There is an important resurgence of tuberculosis in industrialized countries. In 2016, there were more than 10.6 million infections around the world. Most of them were, of course, situated in South Asia and the southern parts of Africa. The only symptom is, in some cases, some vague resting backache. Disease progression in tuberculous spondylitis has 4 distinct patterns. The paradiscal one is the most frequent one for 80%. You also have the central and anterior and the posterior pattern of spread. In the paradiscal pattern, there is a spread from the subchondral end plates into the intervertebral disc space with an hyperintense signal from the end plates and the intervertebral disc. However, the intervertebral disc will be spared because of the Mycobacterium tuberculum has no proteolytic enzymes to digest the disc. Only when there is a progressive erosion from the subchondral end plates, there is a failure of the vascular supply to the intervertebral disc, which will subsequently collapse. From thereof, the pathogen will spread along the longitudinal ligaments to adjacent vertebrae and cause large paravertebral abscesses. You don't see any sclerosis during this reaction. Because when trying to encapsulate the Mycobacterium tuberculum, there are no antigens that are presented to have a normal immune or inflammatory reaction, so the sclerosis remains out, and there is not lots of an inflammatory syndrome. In the anterior pattern of the tuberculous spondylitis, the pathogen sets up from the anterolateral corner and spreads along the anterior longitudinal ligament, causing large anterior abscesses, which can mimic an aortic aneurysm. There is also a stripping of the facies anterior, causing anterior scalloping of the vertebral bodies, and an anterior insufficiency with an early kyphotic deformity. In the central pattern, the pathogen remains in the vertebral body, starting to eccentrically erode away and having a subsequent collapse of the vertebral body and spreading along the longitudinal ligaments to adjacent vertebrae and causing abscesses. The posterior pattern, it's a very infrequent type of pattern. There, the Mycobacterium tuberculum settles in the posterior structures and causes epidural masses, for example. But this type is, as I said, very infrequent, and you should first think of a metastasis, of course, especially in an older patient. In the late stage, there is no discerning pattern. You have a mixture of the anterior, the paradiscal, the posterior pattern, and you get severe kyphotic deformity, in which there is a shortening of the body length of the patient. And when looking closely here in the abdomen, you see large calcified structures. These are granulomatous abscesses, which are replaced by calcified fibrous tissue. The prognosis of tuberculous spondylitis depends on the grade of neurological deficit and deformity. 90% of patients respond well to medicamentous therapy when there are no neurological deficit or deformity present. Some authors advocate prolongation of duration till 12 or 24 months until evidence of radiologic or pathologic regression is proven. What are the indications for surgery? These are progressive bone destruction, abscesses, and lack of neural improvement despite anti-tuberculous therapy, mechanical instability in a patient, severe kyphosis in a young patient, and severe paraplegia. The complications of Pott's disease are Pott's paraplegia. There is an early onset type of Pott's paraplegia. It's caused by a progressive abscess, debris, a concertina collapse in which the interior bulges posteriorly, or meningomyelitis. This demands active treatment. This is a concertina in which these two components move together and there is a bulging of the inside. In the late onset type of Pott's paraplegia, the disease occurs decades after primary infection due to the deformity. This has a worse prognosis because of its irreversible nature. So complications as a deformity and instability. There is a higher risk when the patient has an age younger than 10 years, or there is a kyphosis angle of more than 30 degrees. So in conclusion, there is an important difference between granulomatous and pyogenic spondylitis. And the pyogenic spondylitis, constitutional symptoms are very pronounced, with fever and generalized body aches, while in granulomatous infection, only 20% of patients has constitutional symptoms. This is explained by the fact immune cells cannot present antigens of Mycobacterium tuberculum since they cannot break it down. Pyogenic type of spondylitis is more situated in the lumbar region, while in the tuberculous spondylitis, it's thoracolumbar. In pyogenic type of spondylitis, there is a pronounced destruction of vertebrae and also the intervertebral discs, and there is an extensive sclerosis surrounding the lesion, while in the tuberculous spondylitis, there is a late preservation of the intervertebral disc, since Mycobacterium tuberculum has no proteolytic enzymes to digest the disc. And you don't see lots of sclerosis because of the low inflammatory reaction. In the pyogenic type of spinal infection, you have an enhancement of the infectious mass, while in tuberculous spondylitis, you only see a rim enhancement. The pyogenic spondylitis is limited to some levels, while tuberculous spondylitis typically is a multi-level disease. And in the pyogenic infection, you see abscesses, but compared to tuberculous spondylitis, There you see large masses that can extend into the psoas muscle and the gluteal muscles, which should raise awareness. This leads me to the take-home messages. Tuberculous spondylitis, it's a rare disease, but be aware. Early diagnosis is very important for a good prognosis. There are typical patterns of spread in the infectious diseases of the spine, with difference between children and adults, and the granulomatous versus a pyogenic infection. MR imaging is the modality of choice for the detection of early signs. And you also have the imaging psoas sign on T2 to help you discern between a non-infectious and an infectious pathology. And spinal tuberculosis, there is a discongruence between clinic and severity of radiology findings. I thank you for your attention.
Thank you, Bert, for your very clear overview of spinal infections. Dear attendees, for questions, please use the dedicated box to send your questions right away for our presenters. I have the privilege now to present you Professor Van den Houwer from the University Hospital of Antwerp, and he will give a lecture on spinal trauma. Dear Luc, the floor is yours.
Thank you, Bart, and good afternoon, ladies and gentlemen, dear colleagues, dear friends. It's a pleasure to be here. And in the next 25 minutes, I'd like to share with you my experience in patients with spinal trauma. I would like to give credit to my colleagues who are working with me, and we're working nice together in collecting a lot of cases during the last years. Professor Paradiscal, you might have heard, is not with us in Antwerp anymore. He's now working down under, but we still have good contacts, and he's still with us in all these presentations that we are making for many, many years. So I also want to thank some colleagues who provided me with extra slides, like David Folders from Canada, Fabrice Bonneville from Toulouse, and Pia Sundgren from Lund University. I have no financial disclosures that are related to this topic, and this is the overview of my presentation. After a short introduction, I like to deal with you my experience in imaging modalities, who needs imaging. And most of the talk will be on the classification and newer classification systems for spinal trauma, like TLIX and SLIC, and the AO spine classification system. Due to time constraints, I will not be able to go too much into detail about spinal cord injury, and I hope to provide you at the end of my presentation with some take-home messages. So as a first introduction, I would say I will deal with spinal trauma in the general and adult population, and I will not go into detail about pediatric spinal trauma. Children are not small adults, as you know, and you will find very frequently other things than in adults. Also some variants, like in this child, it's not a fracture of the anterior arch and the posterior arch, but is a congenital anomaly, a fusion anomaly, which is give the split atlas. As you might know, injury to the spinal column is really a devastating injury, and you can see from the slide on the image on the right side what it can do with the spinal cord. It almost can cause a complete transection of the spinal cord with paralysis, tetraparesis, and things like that. So spinal cord injury is really a major cause of disability. And for us radiologists, it's important to provide the clinicians with accurate and fast imaging, just to talk to them about spinal instability, to keep the integrity of the neurological function and not to cause a spinal cord injury. So just to give you some numbers, as you can see, 160,000 spinal injuries in North America each year. 50% occur in the cervical spine. You can see here from the scheme on the right side that indeed 55% of spinal trauma are at the cervical level. And then in the thoracic and lumbar spine, you can see it's divided around 15% for each region. What is also important that it's half of the patient will result in neurological deficits. And this has, of course, significant socioeconomic costs with this. And it can go as up to $1 million per person. Most of them are young, healthy individuals, and most patients will survive their injuries. I think it's not new when I tell you that most individuals that have a spinal injury are young, healthy males, and they are most vulnerable to motor vehicle accidents. But we see now recently that there's a shift to the elderly population. People get older, so they tend to fall frequently. And this can also be, as you can see in 21% of cases, be the cause of a spinal injury. Further on, also sports injuries. And I think the figures differ a little from where in the world you live. I think in Belgium, assaults, gunshot and stabbing, the percentages will be rather low. Okay, let's move to imaging in patients with suspected spine trauma. And I start with the American College of Radiology appropriateness criteria. And I like especially the first phrase. The evaluation of patients with suspected spine trauma is controversial. Sounds good, isn't it? So which patients need imaging? How much imaging is necessary? And exactly what kind of imaging will we use to image these patients? I think most of you will know that CT and MRI are the main imaging techniques. They are complementary. And most of the time we will not go for plain film because plain film really, they are the worst. More than 50% of all fractures will be missed on plain films. 1 out of 3 patients with a dislocation and subluxation might not be seen. Up to 25% of patients with normal X-rays of the C-spine have unstable injuries and as a consequence, possible damage to the spinal cord. So deterioration of neurological status occurs in 10% of patients with initially missed injury, which was only the case in 1.5 patients when fractures were detected. So plain film has largely been supplanted by CT scan. And I would say that plain film with the 3-view cervical spine series is only done if CT is not available. And I think in Europe, and especially not in Belgium, this will be not the case. If we have a patient and we have a plain film, we should look for the overall alignment, change in vertebral body and disc height, focal areas of kyphosis and lordosis, and the interspinous distance. I think it's clear on this sagittal view. You can see there's some translation of this vertebra on the other one, some impaction over here, some widening of the disc space, and we see that the interspinous distance has increased. So this means there must be a ligamentous injury that we must evaluate with other techniques such as MR. I would say dynamic flexion extension, we will not do it in the acute phase. Eventually, we can do it later on in the subacute phase. So CT scan, it's not new. I think if I tell you, it's the imaging modality of the first choice, especially for fracture identification, and it will give you good images in regions that are difficult for plain film, which is the cervicothoracic junction and the craniocervical junction. And you should know that 1 out of 3 injuries to the cervical injuries will happen on the level of the craniocervical junction. CT, a high detection rate, as you can see. And just to give you an example, a 74-year-old woman, she fell out of bed on the plain film. Well, maybe something must be wrong over there. But if you take down a look at the CT images, I think it's much easier to detect this fracture through the base of C2, and you can understand the complex anatomy on the coronal and the sagittal images. On the soft tissue window settings, you see something is wrong. There seems to be a hematoma over here with narrowing of the spinal canal. But if we want to understand what's really going on, we would need MR, because MR is the better technique for soft tissue injuries. Another example, we see a patient with a fracture. See it over here, looks like a teardrop fracture on plain film. We see the increase in the interspinous distance. This is the CT scan, nicely demonstrating you the small fragments. The facet joints are intact, which is good news. So this is the C4 flexion teardrop fracture. But what's going on in the posterior soft tissues, in the ligaments? What's going on there? Well, to see that, we need MRI, because because of its superior contrast resolution, it would much better show us, is there edema, is there a rupture of the ligaments. So really, MRI is the golden standard for soft tissue injury, not only to the intervertebral discs in the spinal ligaments to evaluate spinal instability, but also for other structures like the spinal cord and the nerve roots if we have a patient presenting with a neurological deficit. And these soft tissue injuries are identified in 5 to 24% of patients with negative CT scans. If we want to use these new classification systems like SLIC and CLICS, we will see that we need more MR imaging done in our patients because we have to evaluate the discoligamentous complex and the posterior ligamentous complex. What is the posterior ligamentous complex? Well, it's the posterior longitudinal ligaments, the interspinous and the supraspinous ligaments, the flywheel ligaments, and the facet joint capsules. So just to give you the same example, the same patients, if you look at the MR images, we nicely will see the fragment with some edema in the bone marrow. I think you nicely can recognize the prevertebral hematoma. And you also will notice that there's something wrong in the posterior epidural space. And of course, on the STIR images, you nicely can see there is edema, there is soft tissue injury to the posterior ligamentous complex, which may cause instability in this patient. So more images showing on the actual T2 image the epidural hematoma. So these are the imaging protocol. We use sagittal T1 and sagittal T2. We go for axial gradient echo and spin echo T2. But I guess that the most important sequence in imaging patients with a spinal trauma is the sagittal STIR image. Not only very sensitive for the edema, the soft tissues, in the bone marrow, but also in the spinal cord. So this is really a sequence which is very important. Also, we'll find non-contiguous vertebral injury with some edema in the subgenral bone marrow, which you typically can find in patients that fall down. What is important is that MRI should best be performed within the 72 hours after the injury. Not only in the acute phase, MR can be useful, but also later on when there is persisting pain, it can be useful to perform MR and look what is going on in these patients. There is some problem with MRI. There seems to be a tendency to overestimate soft tissue injuries. And so this might result in false positive results. And this may bring with it a risk for potential unnecessary surgical procedures. So that's one of the reasons why the SLIC and CLICS classification have now been left alone, and we go now more for the AO spine classification. Another reason to do that is that the limited access in developing countries and in small hospitals with a very busy MR unit, it can be difficult to have the patient into the magnet. So who needs imaging? I think everyone will agree in a patient with a polytrauma, we will use a polytrauma protocol. We do an MDCT of the brain, the neck, chest, abdomen, and pelvis, and we can make nice reconstructions of the spine, which is in these parts of the body. So the head, we see a huge hematoma, intracranial. The C-spine looks okay from posteriorly. Let's take a look at the thoracic and lumbar spine. Not too much great abnormalities, but take a look at the cranial-cervical junction. These two paired structures that you see over here are the occipital condyles, and as you can see, they are not in the wrong position. They translated anteriorly, so this is actually a case of an atlanto-occipital dissociation, also called as internal decapitation. What to do in a patient, the walking wounded patient? Which techniques will we use? And fortunately enough, there are some decision rules to identify these patients because we don't want to do too much imaging in patients that don't need it. So there are for the cervical spine some rules, the Canadian C-spine rule, and these are the criteria that should be looked for. And if they are all there in the patient, no imaging is needed. Same is for the Nexus study. They also found that no imaging is needed if patients follow all these guidelines. Another important criteria is the Harborview high risk criteria. And if there's any of these criteria listed over here, then this warrants to go for a CT scan of the spine. And so from Professor Van Gouten, I got this imaging algorithm. So if you have a patient with a spinal trauma, you follow the Canadian C-spine rule and the nexus rule. If there's nothing to do, there's no reason for imaging, it will stop. Then you go to the Harborview criteria. And if you find any criteria that is positive, you have to do a multi-detector CT. If not, you can eventually perform plain film imaging. And I got actually this scheme from the chapter in the ESNR textbook, Clinical Neuroradiology. It is a free book for the members of the ESNR Society. For the thoracic and lumbar spine, there unfortunately are not validated criteria. And clinical examination is very difficult in these patients, so there will be a low threshold, especially in high-risk patients, elderly patients, high velocity or high energy mechanism. When there's underlying diseases like this, patients with a stiff neck, we will do imaging, and most of the time we will do CT scan because it's really the gold standard. MRI is not indicated if CT is normal, but if there are any neurological abnormalities, I would really suggest to go for MR imaging to rule out spinal cord injury. Just an example, see a patient with some fractures at the level of the skull, and we see there is a burst fracture at the lumbar level. You nicely can see it on the axial images. You make the sagittal images, and you can see that these burst fractures really show retropulsion of the posterior wall with a spinal stenosis and possible a conflict with the nerve roots of the cauda equina. Also notice the fracture in the posterior elements over there. Okay, this brings me to the biggest part of my talk, which is the classification. Classifications, why? Well, to improve communication with our colleagues, both radiologists and clinicians, because it might guide the clinical and surgical treatment in these patients. The ideal classification system should be easy to use, should be reproducible, and it should focus on characteristics that are relevant for the prognosis and for therapeutic decision making. There are many different classification systems, and I will not go too much into detail in the history of them. Maybe you know that most of them go into the pathophysiology, and as you might know, hyperflexion injuries are the most common type of injury, 50 to 60%, but you also might have injury due to hyperextension, rotational and shearing injury, and combinations of these four major patterns. So this is all kind of classification system related to the spine, and you can see if you have to know all these classification systems, it gets very cumbersome. Unfortunately, we can simplify this slide a little. In the United States, they were very fond of the Dennis 3-column classification system, while in Europe, there was a lot to do on the AO classification system by Magro. Unfortunately, there are 40 subtypes of fractures, so there was a lot of interradial variability. So fortunately enough, it was Mr. Vaccaro, a spine surgeon from Philadelphia, who developed the TLIX classification and the AO spine classification. So let's take a look and go more into detail. This is the old Dennis classification. I think you all know it very well. We use it to say if a lesion is stable or unstable. We have 3 columns. The anterior 2/3, posterior 1/3 is the middle column of the vertebral bodies and the disc spaces. Anteriorly, we'll have the anterior longitudinal ligament. Posteriorly, we have the posterior longitudinal ligament. And in the 3rd column, we have the posterior elements, both bony, muscles, and ligaments. And we know if there is more than 1 column injured in the same time, this means it's an unstable injury. I hope you are not using this classification system anymore, because there are better classification systems, like, for instance, the CLIX and the SLIC classification. We are not only looking to morphology in the images, we are not looking at the morphology of the trauma, but we will also incorporate the neurological status of our patient, and this is new. Further on, for us important as radiologists, there is a big focus on the posterior ligamentous complex. So let's start with the TLIX classification, which is both a scoring and a classification system. And in each patient, there are three variables we should look at: injury morphology and integrity of the posterior ligamentous complex. That's the job we have to do as radiologists. The neurologic status, we leave it to the clinician. And you can see for all these morphological changes, the patient gets a point. And if we add the points together, we will have a spine injury score. And depending on the score, it is when the score is low, we can perform a conservative treatment. If the score is above 5, for instance, it means we have to go for surgical treatment. In between, we can use both conservative and surgical treatment. PLC injury, as I told you before, are potential unstable injury, and MR is really the best technique for this posterior ligamentous structure. And as I already showed you, the STIR imaging is the best sequence. If MR is not available, of course, we can have some clue from the CT scan. If we see an increased interspinous distance, like in this patient, if we see there is widening of the posterior aspect of the disc space, I think it's clear to anyone that there must be a posterior ligamentous rupture. So just to give you an example, this is a patient who had a trauma, and we see for the injury morphology, we have a burst fracture, so it means the patient gets 2 points. We see abnormal signal intensity in the posterior ligamentous complex. It is not clear whether it's really a rupture. So if it's a rupture, we can give it a 3. If we are uncertain, we give it a 2. In this case, we gave it a 2, and the neurological status is okay, so 0 points. So in the end, the injury severity is scored, so we can apply both conservative and surgical treatment in these patients. The same kind of method is applied for the subaxial cervical spine. So subaxial means C3 till C7, and you can see that 50% of injuries are between the C5 and C7 part of the C-spine. And what is important is that many patients, especially elderly, may have pre-existing diseases, and these will be used in modifiers for the AO spine, as I will talk to you about later. So same mechanism, we have to look for injury morphology. We look at the discoligamentous complex, the DLC, which is actually the PLC, and we add the anterior ligamentous complex. And also here, we can calculate the injury severity score. Just to give you some examples, this is a compression fracture, you get a 1 point for that. If there's a burst component, you get 2 points. If there's distraction, as you can see here on the MR, you get 3 points. And when there's translation, anterior movement, you get 4 points. This is the evaluation of the DLC on MR imaging. This is a patient with a whiplash injury with maybe some disc problem over here, but the other structures are intact, so 0 points. This is the patient I showed you before with some edema in the posterior ligamentous structure. So it's indeterminate whether there's a real rupture, so we give it 1 point. Here, you nicely can see that there's a real rupture here in the posterior ligamentous structure, so there's really a disruption, so then you get 2 points. So same mechanism, you give the score, and if the total score is under 3, you do a non-surgical approach. If it's 5 or more, you will go for surgery. And when it is 4, it's undetermined, and then you leave it to the neurosurgeon. Just to give you an example, a case given to me by Erik Ransgaard, an 80-year-old woman who fall during the gym with neck pain, but no neurological deficit. We see there's a fracture in the facet over here. You see there's some translation over here. You see there's a fracture on the facet that you could also evaluate over there. And you see there is some rotation over there. So we have translation or rotation, which gives you 4 points. The DLC, well, there is some slight high signal intensity over here. So let's call it indeterminate. So we have already 5 points. So the injury severity score is 5. So this calls for surgical intervention. Just to show you why the AO spine classification has replaced the other classification, we will focus more on the injury morphology over here, and the other classifiers are the neurological status and some modifiers. If you go to this website, you will find all the classification systems that they use for the spine, because they have not only classification system for spinal trauma of the thoracolumbar spine and the subaxial C-spine, but they also have a classification system for the craniocervical junction and for the sacrum. But let's start to have a look at the AO spine for the thoracolumbar joint. You see A are compression injuries, B, distraction injuries, and C are translation injuries. Just to give you an example, this is an incomplete burst fracture, posterior involvement of the posterior wall, but only end plates involved. So this is an A3 fracture. If you have a patient like this, where you have a problem with the tension band, the anterior tension band, we call it the B3 fracture. And you should start to classify this patient to look for, is there translation? No. Is there no translation? Is there the lesion of the tension band? Well, then you can look for that. If no, you go to look for fractures, and then you find all these detailed elements, and so you can give a nice overview to your clinician. There are not only the neurological elements, but also some modifiers. If you're not sure whether the posterior ligamentous complex is intact, you can add one extra point to that, because there's also this injury score based on the AO spine injury, and you can give the points on the morphology of the patient, the neurological status, and the modifiers. And also here, if you have a low score, you can go for conservative treatment. If you have a high score, you go for surgery, and in between, you can leave it to the clinician. The same has been done for the C-spine, compression injuries, tension band injuries, and translation injuries. Just a patient we saw before, a patient with a B2 posterior tension band injury. What is typical for the subaxial C-spine is that we have to score the facet injuries. So let's take a look at the patient we saw before. How would we call that? With the SLIC classification, the patient would have a score of 2. There's no injury score ready for the AO spine, but we would call it a C3, C4, B2 fracture or tension band injury, and with an A1 fracture of the C4 vertebral corpus. So the subaxial C AO spine injury score is work in progress, and this brings me actually to my take-home messages. I think that I could show to you that the radiological investigation is really very important in the diagnosis and management of patients presenting with a spinal trauma. And I think I showed you that CT and MR are the most important techniques, and they are complementary. CT is used in the acute phase. We have to detect and describe the morphology of the fractures. MRI done within 72 hours after the injury. We go for the soft tissue injuries, the PLC and the DLC, and we can integrate both scores into the spine classifications. If you have a patient with a neurological deficit, MRI is definitely the first choice of examination. With that, I'd like to thank you for your attention.
Thank you, Luc, for your dedicated talk on spinal trauma and its classification, and it will be very helpful in our daily work as radiologists. To repeat, dear attendees, for any questions, please use the dedicated box to send your questions to all the panel members. They will talk about it or will give you any answers at the end of these lectures. I'm now very honored to present to you Professor Kasselman from the St. John's Hospital in Bruges for his next lecture. He will be talking us about black blood imaging. The floor is yours, Jan.
So thank you very much for the introduction, Bart. And I will talk you in 35 minutes about the black blood imaging and the applications in neuroradiology, the skull base. Now, first of all, a little bit about the history of black blood. It was first used in the 90s to look at the vessels in the heart and the neck, because you could have vessels with black blood inside and only seeing the vessels. In the early 2000s, the first applications appeared for intracranial vessels, and we had to wait for 3D black blood imaging intracranially to 2010. And it was only recently, 2015 to 17, that we started using black blood in the brain itself, no longer in the vessels alone. Now, what are the techniques that are used? Well, in the past, it was stir and spin echo sequence with a flow saturation pulse to eliminate the signal of the flowing blood. Later on, gradient echo, faster sequences with single shot T1 and T2 were used with nulling of the suppression of the vascular signal. And today, to look at the brain, we are actually using motion sensitized driven equilibrium pulses, which are causing dephasing of all moving spins and especially are crushing the relatively fast moving spins. That makes the vessels look black. This is how it looks like. You are using motion sensitized driven equilibrium with sensitizing gradients so that the blood, even if you use gadolinium, the blood inside the vessels remains black. This sequence has several advantages. It is a T1 turbospin echo. That means you have no susceptibility artifacts at the skull base. Further, we see that the sequence is isotropic, so we have sharp reformatted images. Further, I see it's a little bit mic level. I try to lower that. So further, it's isotropic, so your reformatted images will have the same image quality. And the best signal to noise is achieved when we are using a 32-channel head coil on a 3 Tesla system. Why do we need that? Because MSDE comes with a price at signal to noise. You lose signal to noise. And further, it will affect contrast due its T2 prep-like nature. So it will look like a T2 weighted image, but in fact, it is a T1 weighted sequence. We use it in the brain, isotropic 0.8, but if you, of course, go to the skull base, you need higher resolution. And there we go, 0.55 in the 3 directions. These are long sequences, and therefore we need new techniques to speed it up, like compressed sense. If we would use it without compressed sense, it would take 5 minutes for the brain. Now we go to 3.30. If temporal bone would be 9 minutes, we do half of the time off with compressed sense, and we can run these sequences in 5. So here you see an example of a black blood isotropic sequence, and you see that is the routine one. This is the one with compressed sense. There's no difference in quality, and we just gain a lot of time, and so we can do this kind of sequences. If we are going to do that for the temporal bone, you see 4 minutes off, and we have exactly the same image for the brain. It's about 30% shorter with compressed sense. Okay, you don't have to make any advertising for it. If you show these images to your clinicians, 2 weeks later they are there and they ask, I want this sequence for this patient. So they immediately see the advantages of it, and the most obvious advantages are actually the meningitis, MS, vasculitis, and metastasis. Now we have 3 years experience, and we still discover every week new applications. And in most of our applications in neuro today, the black blood is already displacing T1. And we're going to have a look. Okay, hitting the webcam. How can I open this one? Is it back? Okay. So here we have the applications in the brain: orbit, temporal bone, pituitary gland, and skull base. So this is what we try to do. We are going to look first at the brain. And if you look at the brain, here we see that we are looking at brain images with metastasis. This is the T1. And if we are looking here at the vessels, I have to look for the skull. One moment. Yeah. Okay. So here we have enhancement in the brain. This is a metastasis, but if we look on the T1, it just looks like a vessel. So we missed that one. Here we have another example. This is a metastasis, but we thought these were vessels, but this is leptomeningeal enhancement. And here we have another example. We thought this was a deep vessel, and actually it is a metastasis. And you see that the black blood is correcting all the time your T1 weighted images. Also for not only metastasis, but for the meninges. What you see here is actually that we have a metastasis, and then we see that there is more than that. There are the meninges that are always enhancing all around on T1, but look on the black blood, you can see that it's only this part. Normal meninges are not seen on the black blood, only the metastasis is seen. So you would not see that here on the T1 weighted image, but would see that very clearly on your black blood sequence where we have the thickened meninges. So once again, a big advantage, you can see the meninges. And here we have an example of a patient where we saw meningeal enhancement, and these were metastases of a melanoma. We called that metastasis. The T1 was negative. They didn't believe us, just waited 3 months later for the follow-up. And then you see that they couldn't control it with therapy. And we have metastasis all the way on the meninges. And you can also see it now on the T1 at that time. So you see that you have a very sensitive sequence.
No images.
We have a small technical problem. Could you please have a look to your presentation? We don't see your presentation. Sorry for that.
You don't see the presentation. And where do I have to click?
I will
restart.
Just a second.
Yeah. Okay.
And I will. Voila. Now you should
show
be
my screen.
able to...
Okay. Do you have it?
No.
Can you see it?
Sorry, no.
Because now I've just accepted the screen.
At the moment, we don't have your presentation, so.
So maybe what we can do is that I log out completely and log in again. Because I see my video is on, my mic is on, and there's nothing else. Show. Because you were seeing it at the beginning?
Yes, that was correct, and then it went away. So we are probably looking at the wrong screen from your computer. Sorry for that.
Do I log out and log in again?
I don't know, Bart.
Can we go to the next speaker, to Professor Castillo, and then Jan can order out his problem?
Yes, I think that's a good decision. Yeah.
Okay.
Can we have Professor Castillo online now?
You should have me online.
Okay. Sorry, dear attendees, for this technical interruption, but we will manage that in a few minutes. I want to present to you now Professor Marcelo Castillo, who will talk us about 2 lectures. He will give us today 2 lectures, and I'm just gonna skip. He's gonna give a lecture about inflammatory and vascular disorders, and just after that, he will talk about errors in emergency neuroimaging. Professor Castillo, thank you for joining us from the US, and I give you the platform. Thank you.
Bart, many thanks for the introduction and for inviting me. I just want to make sure that you can see my screen.
Perfect.
You can see it. Okay. So very happy to be with all of you here this afternoon. In the next 60 minutes, I'm going to be giving 2 lectures. The first one of them will deal with diseases that we see in adults, predominantly in the white matter. So we're going to review some current thinking on adult inflammatory demyelinating disease. And then in the second 15 minutes of the lecture, we're going to talk about these white matter abnormalities that we see particularly in elderly adults on a daily basis, what to do with them. I think it's a very common topic and a very common finding on imaging, and we need some background information in it. So we're going to start by looking at the 5 white matter inflammatory demyelinating and probably immunologically related disorders that are now recognized as different and distinct entities. First one will be MS. Second, we'll talk about neuromyelitis optica. Then mention a little bit about MOG encephalomyelitis. Then we're going to talk about the neurofasching disease, which is a disease that tends to affect, in the majority of patients, the peripheral nervous system, but in a small percentage of them also affects the central nervous system. And then we're going to finish with the NMDA receptor encephalitis, which, as you know, is basically a paraneoplastic disease. I am not going to be talking about acute disseminated encephalomyelitis because that is a disease that, although it tends to involve the white matter, it involves also the gray matter and is predominantly a disease of children. And in the next 15 minutes, I am going to talk about diseases of adults. So let's begin with reminding everybody that multiple sclerosis is a disease characterized by dissemination in time and dissemination in space. Dissemination in time can be seen as presence of enhancing and non-enhancing lesions, like you see on the slide. I'm sorry, the arrows are not there. Or the appearance of new lesions on non-gadolinium MR, that is the appearance of new lesions on T2 weighted images. Dissemination in space is seen as the presence of one or more juxtacortical lesions and one or more periventricular lesions. On the FLAIR image on the left hand of the slide, you can see several juxtacortical lesions and several periventricular lesions. Those periventricular lesions may involve the white matter just lateral to the lateral ventricles, or they may involve the corpus callosum. They are grouped within the same space. And then juxtacortical lesions are those ones that will involve the subcortical white matter and at the same time the gray matter. Now, a question that I get often asked is, do we need contrast enhancement to image patients with multiple sclerosis? Since both dissemination in time and in space can be seen on T2 and in FLAIR, should we really be given contrast gadolinium for these patients? And the answer is probably no. At our institution, we use it for the first time the patients get an MR study of the brain and spine. We use it for those patients that are on research protocols. We do not use gadolinium for the routine follow-up studies in patients with MS. And if we need gadolinium, we use macrocyclic compounds for both the adults and the children. Second question that I often get asked is gadolinium needed for optic neuritis? And the answer, again, is probably no. You can make a diagnosis of optic neuritis by just obtaining fat-suppressed coronal T2 weighted images in which you will see increased thickness and signal intensity, not only of the optic nerve, but also the dural sheath and many times of the adjacent fat. Although we have been taught that optic neuritis is a disease exclusively of the optic nerve, in reality, it is a much more extensive inflammation involving not only the optic nerve, but the subarachnoid space that surrounds the nerve, its sheath, and many times the adjacent fat. Here's an article published last year in the AJNR in which they took a look to see if gadolinium was truly needed for routine follow-up MRI in MS. And what they concluded was that 95% of all enhancing lesions were detected on the double inversion recovery sequence or on the FLAIR images. The only lesions that were missed were those ones that were very small or those ones that were located within large confluent abnormalities. And the significance of this is that probably missing these type of lesions does not change the management of the patient. So this article confirms the fact that you perhaps do not need gadolinium for routine follow-up of MS patients. Now, what can you see in patients that have MS using susceptibility weighted imaging? You can see two things: the central vein sign, which is seen in the majority of plaques and has a very high specificity. And you can see this very curious process, which is called chronic persistent active inflammation. This is seen as black rims around the plaque. These black rims are probably macrophages, so they're active immunological cells causing inflammation that contain iron. And from a clinical standpoint, the most important thing is that these plaques that demonstrate chronic persistent activity do not remyelinate. Both of the things are better seen on susceptibility weighted imaging obtained at 3 Tesla, but you can see them also at at 7 Tesla, but you can see them also at 3 Tesla, and I'm going to show you examples. On the top of the slide, you see on the left hand, 2 plaques. They show no contrast enhancement. They're bright on T2. And if you pay close attention on the susceptibility weighted images, you see black rims surrounding them. Those are chronically active plaques. There is an ongoing inflammatory process that implies perhaps that the medication is not working, or that these plaques have a worse prognosis than those ones that do not have those black rims. On the bottom of the slides, the arrows are pointing on the susceptibility weighted imaging to veins that are crossing through the central aspect of the plaques, the so-called central vein sign, which, as I said, is found in the majority of plaques, and it tends to be highly specific for multiple sclerosis, which, as you know, is a perivenular inflammatory demyelinating process. Okay, now let's talk about neuromyelitis optica. We used to know it as Devic's disease. Now we know it as NMO spectrum of diseases because there are several forms. The most common form is one that affects the optic nerves and the spinal cord in close temporal relationship. The lesions in the spinal cord tend to be very long, over 3 segments in length, unlike the multiple sclerosis ones that are very small, 1 segment. There is a limited form that affects the brainstem, the diencephalon in the cerebral hemispheres. It has a much worse prognosis than MS because it is not only an inflammatory process, but it is also a necrotizing process. It is seen more common in Latin America and in Asia, and in about 1 to 3% of patients, there will be relapses. So typical example, very long T2 weighted cord lesion from the bottom of the 4th ventricle to the mid-thoracic spine with a lot of patchy gadolinium enhancement. And on the right hand of the slide, you see very swollen and deeply enhancing optic nerves in their prechiasmatic portion. Typical findings, all of this occurring at the same time. Basically, the only thing that can do it is NMO, or at least the thing that should be on the top of your differential diagnosis is NMO. Second patient, long white matter T2 lesion on the cord involving from the bottom of the 4th ventricle to about C4, almost a rim enhancement pattern, which can be confused with a neoplasia. But in this patient, both optic nerves in their intraorbital portion and prechiasmatic portion show significant swelling and significant contrast enhancement. These things occurring at the same time are very suggestive of NMO. A lesion at the level of the bottom of the 4th ventricle along its floor is also very suggestive of NMO. What is NMO? NMO is a disease in which an antibody binds to a protein called aquaporin 4. Aquaporin 4 is a protein found at the interfaces between the brain and the CSF. When this antibody binds to this protein, it incites an inflammatory reaction that results in the destruction of astrocytes. The most common sites for the presence of aquaporin 4 in the central nervous system are the optic nerves and the spinal cord. We already said that those are the places predominantly involved by this disease. The area postrema, in many patients present with intractable vomiting, the hypothalamus, and the area of the lamina terminalis. When I was a medical student about 40 years ago, we used to call these the circumventricular organs. About 10% of patients with NMO will show brain abnormalities. You see on the FLAIR image the involvement of the floor of the 4th ventricle. You see involvement around the inferior 3rd ventricle, the hypothalamus, and following gadolinium administration on the right hand of the slide, you see this patchy enhancement at the CSF brain interfaces. Here's another patient. Again, on the left hand of the slide, small area of signal abnormality involving the inferior anterior floor of the 4th ventricle, the area postrema, around the lamina terminalis seen on the FLAIR image, and following gadolinium enhancement, you see enhancement of the area of the lamina terminalis, and if you pay close attention, there is swelling and enhancement of the prechiasmatic portion of the optic nerves bilaterally. All of these findings highly suggestive of NMO. Okay, let's switch now and talk about MOG-related encephalomyelitis. MOG is a protein that is expressed in the myelin sheaths. and there is an antibody of IgG type that attacks this protein. It is predominantly a disease of children and young adults. When it involves young adults, it occurs in the 4th decade of life. That is about a decade later than most patients with multiple sclerosis will present. Like multiple sclerosis, it is a disease that predominantly affects women. It is not linked to infections or vaccines, so it is not ADEM. And it most frequently presents with seizures. It is highly unlikely that MS and NMO will present with seizures, while seizures are highly likely in MOG encephalomyelitis. Unfortunately, the brain findings tend to be fairly nonspecific. In this patient, you see several white matter or bright signal intensity lesions in the periventricular white matter posteriorly. You see similar abnormalities on the superior and inferior aspect of the brainstem, and you see a lesion involving the left middle cerebellar peduncle. Apparently, lesions in the left middle in the cerebellar peduncle, are typical of MOG. So what are some of the distinctive clinical features that separate these 3 diseases? Well, optic neuritis is much more commonly seen in aquaporin 4, but is also quite commonly seen in MOG and MS. If the optic neuritis is bilateral, it is more commonly seen in MOG and less commonly seen in aquaporin 4 or NMO disease, and it is a rare thing in multiple sclerosis. Spinal cord lesions, patients with NMO, you'll find them in nearly all patients. You find them in slightly more than half of patients that have MOG, but long cord lesions are very rare in MS. Remember that we said that in MS, the majority of lesions in the spinal cord tend to be short, less than 1 vertebral body in length. Brainstem involvement, much more common in MOG encephalomyelitis, and brain lesions are nearly universal in all patients with multiple sclerosis, but occur only in 10% of patients that have aquaporin 4 or NMO, and only in about 1/3 of the patients that present with MOG encephalomyelitis. Okay, here's another patient with MOG. We have several T2 weighted images and a gadolinium fat suppressed image. You see the swelling and high signal intensity of the right optic nerve. On the coronal stir image, you see involvement bilaterally of the optic nerves, perhaps right greater than left. And following gadolinium administration, you see the typical findings of this inflammatory process involving the optic nerves, similar to the findings that I already mentioned in MS. You have swelling and enhancement of the optic nerves, you have enhancement of the optic sheath, and you have this dirty, nearly enhancing fat that surrounds the optic nerves and their optic sheaths. Okay, some things about the labs that we see in these 3 diseases. In MS, obviously antibodies against aquaporin 4 and MOG are going to be negative. Nearly all patients will show oligoclonal bands in CSF, and over 80% of patients will demonstrate antibodies against measles, rubella, and varicella. In NMO or aquaporin 4, those antibodies are going to be positive. Oligoclonal bands are seen in less than 1/3 of patients. And the antibodies, again, the measles, rubella, and varicella are almost non-existent. In MOG disease, like we mentioned before, the antibody against this protein is going to be positive. Again, oligoclonal bands are very rare, and antibodies for measles, rubella, and varicella are also going to be very rare. So there are not only distinct clinical, but laboratory findings in all of these patients that should help you separate these diseases into 3 diseases that clinically behave differently and are going to require different treatments and have different prognosis for the patients. Okay, let's talk about the anti-neurofascian disease. As I said before, this is a peripheral demyelinating disease that tends to affect the nodes around the ear, and we clinically know it as CIDP, chronic inflammatory demyelinating polyneuropathy. But about 10% of these patients will have brain involvement, and when the brain is involved, they have lesions that look identical to those ones that you will see in patients with MS. When the brain is involved, it receives the name of CCPD, combined central and peripheral demyelination. Here's a patient on the top left hand of the slide. You see paraventricular white matter lesions very similar on this FLAIR image to what you would expect to see in a patient with MS. Inferior to that image, you see enhancement and swelling of the trigeminal nerves bilaterally. On the coronal image, you see very clearly swelling and enhancement of the third division of the trigeminal nerves. On the top right hand of the slide, swelling and enhancing infraorbital nerves. And in the two images on the bottom of that one, you see diffuse swelling of nerve roots and diffuse swelling of the brachial plexus bilaterally, involving the roots and the trunks of the brachial plexus. So this is a combined type of demyelination called CCDP. Is not only affecting the peripheral nervous system, but it's affecting the central nervous system. In the past, we used to think that CIDP could occur in patients with multiple sclerosis. We know that that is not true, that this is a combined disease now named CCPD. Okay, let's switch now and talk about the last of these disorders, the anti-NMDA receptor encephalitis. These antibodies will target the receptors of this substance that is predominantly found in the temporal lobes, and that is why these patients commonly present with seizures and memory abnormalities. About half of these patients will have a neoplasia. The most common neoplasia to produce this type of encephalitis is an ovarian teratoma. So most of these patients are going to be female, and the encephalitis related to the presence of an ovarian teratoma is the most common paraneoplastic syndrome. Two patients on the left hand of the slide, you see swelling of the head of the hippocampi and the amygdala. You see the same thing on the axial image bilaterally. In the other patient, you see similar findings, perhaps greater on the left than on the right. On the coronal image, again, you see signal intensity that is increased inside the hippocampus bilaterally, but notice that again on the left side, that those findings are much more extensive, and there's more swelling of the hippocampus and compression of the subicular white matter. Okay, so now we're about halfway through the lecture, and I'm going to leave behind the inflammatory, demyelinating autoimmune processes that we spoke about, and I'm going to turn into these white matter abnormalities that we see on a daily basis in adults. And the problem that we have begins with what we call them. Less than 50% of experts agree on what to call them, and we call them anything from cerebral small vessel disease to paraventricular white matter changes to chronic ischemic changes, age-related changes. Some of us just call them white matter hyperintensities. Other people have even confused the situation even more by including names that relate to clinical conditions or pathological findings such as leukoariosis or Binswanger-like changes. I don't like to use those terms. I am as non-specific as I can be when I look at these things. So your differential diagnosis is going to be very different if you find some paraventricular white matter lesions in a 24-year-old than if you see them on a 65-year-old. On the top, you see paraventricular white matter lesions on the FLAIR images in a young woman. Obviously, your differential diagnosis should start with MS, vasculitis, and many other things. And only at the very end of your differential diagnosis, you will include this microvascular white matter disease that we see in adults. That will be extremely unlikely on a 24-year-old unless there are significant predisposing conditions. On the bottom of the slide, you see a 65-year-old. He has this patchy, somewhat posteriorly confluent white matter stuff. This one you will have no problem calling microvascular disease or white matter changes of aging. Your differential diagnosis no longer includes that long list, but it is compressed into a single entity that is probably going to be the reason for these things. If we try to find out what's the reason for these things, and you look at the medical history of the patients, I don't know, probably in Belgium you don't have these patients with this chronic list of findings like we have here, but this is the problem list that I took a picture from the medical record of the patient. You can see that this patient has many underlying conditions that may explain on an individual or on a group basis the MRI brain findings. He has essential hypertension, he has migraines, and he's a diabetic. And at least where I live, the incidence of diabetes type 2 to obesity is tremendously high. Okay, what's happening to the blood vessels that leads to these white matter changes? Things are happening both on the arterial side and on the venous side. On the arterial side, you get this degenerative process of the wall that's called lipohyalinosis. You have small clots inside the blood vessels leading to luminal narrowing. You have loss of muscle from the vessel wall. But not only are the arteries affected, the veins are going to be affected, and they have a degenerative process called collagenesis. And at one time, about 20 years ago, it was felt that these white matter changes were probably from a venous origin rather than from an arterial system. I think that now we believe that their origin is accounted by both changes in the arteries and veins. These changes lead to apoptosis, demyelination, spongiosis, and because they are little microatheromas, you can have infarcts, which are generally of the lacunar type. Why is the white matter more affected than the gray matter? Because of its blood supply. Remember that not only does the white matter get less blood, about only a third as the gray matter, but it's also a watershed or a terminal zone with scars and anastomosis. So if something happened to the major blood vessels, it is the deep white matter that is going to suffer. And these pathologic changes will result in loss of autoregulation, fluctuations of your cerebral blood flow, a damaged blood-brain barrier, all of those leading to a loss and death of oligodendrocytes, which translates to a loss of myelinated fibers. Okay, what are you going to do with these lesions? How many of them are you allowed to have? Well, we always teach our residents that you can have one per decade of life. So I should have at least 7. I'm not sure how many I have. In reality, there's no proof that this is true, but this is what we teach our residents and we accept. After 60 years of age, a great majority of us will have white matter lesions. And generally, these white matter lesions start around 50 years of age. They are much more common when the lateral ventricles are large. They tend to be periventricular, like I said. They occur on both sides and are fairly symmetric in nearly all patients. And in about a fifth of the patients, they will affect the pons. And you should always report these ones that affect the pons, because when you see involvement of the pons, generally you see significant periventricular white matter disease. Now, how do we grade it? For literature and research purposes, it has been graded according to the Fonseca scale. But you can divide it only into mild, which are focal scatter lesions, moderate, which there's focal scatter lesions, there's more of them, and they're beginning to get somewhat confluent, particularly posteriorly, and then you can call it severe when there's no focal lesions, but all of them have become diffuse and confluent, as you see on the slide, on the right hand of the slide. So I myself just use a very subjective grading of mild, moderate, and severe, always correlated with the age of the patient. The reality is that if you're able to age successfully, if you're not a smoker, if you take care of your weight, if your diet is good and your cholesterol is not elevated, if you exercise, you should be able to get to 80 or 90 years of age with no or very few periventricular white matter lesions. Periventricular white matter lesions, particularly for those of us who work in teaching hospitals, are very common because our patients have many underlying disorders. Okay, what are they associated with? Increasing age, females, African origin. You are very lucky in Belgium because they're much less common in white Europeans. Smoking and alcohol. Your level of hemoglobin A1C is closely associated with them. Hypertension and silent strokes. Also associated with the presence of microbleeds on susceptibility weighted images, particularly microbleeds located in the central aspect of the brain. And obviously, this is a socioeconomic disorder. It is much more commonly seen in families, at least in the United States, that have an income of less than $50,000 per year. Okay, so on the top of the slide, you have a patient. The FLAIR image around the ventricles shows a lot of white matter stuff. I would call this probably severe white matter disease. This patient is presenting with weakness on the right side of the body. And when you look at the diffusion weighted images, you see a small lacunar infarct in the left posterior capsulothalamic area, explaining the weakness of the patient. As I said before, most of these patients have infarcts, and when they have these infarcts, they're going to be of the lacunar type. These changes are associated with a faster onset of dementia, but only when there are other findings, such as microbleeds in lacunar infarcts. They are associated with abnormality of gait and urinary incontinence, and as seen on the patient on top of the slide, they are associated with an increased risk of stroke. Okay, what are the imaging features of these things that we've been talking about? We said before, more or less confluent in the frontoparietal parentricular white matter, but they can be anywhere from the surface of the ventricle to the subcortical white matter, like in the case that you see on the right hand of the slide. They tend to be bright on flare and T2, better seen on flare than on T2. And you shouldn't call them parentricular white matter disease if the area of signal intensity abnormality is adjacent to an area of cortical damage and loss of volume, as seen in this patient pointed by the arrow. That is gliosis secondary to an infarct. So you shouldn't call that parentricular white matter disease. The other stuff that you see in here, deep and superficial, that is the white matter disease that we've been talking about for the last 12 or 13 minutes. So how do I report them? I don't know how do you report them, but generally, for me, if a patient is less than 60 years old, I count them as their few, and I say, oh, there's 4 or 5 non-specific parentricular white matter T2 signal intensity abnormalities. If the patient is above 60 years of age, we said these things are very, very common. So perhaps it's just better to call them mild, moderate, or severe. They're confluent. Always mention if there's similar findings in the pons. We already said that about 20% of these patients will have signal intensity abnormalities in the pons. And always mention associated lesions such as cerebral microbleeds and lacunar infarcts. Remember that we also said a few minutes ago that these are the patients that tend to develop other complications such as dementia. So it is important to mention them. Now, do they progress? Here's an article published a few years ago in The Lancet. They had the opportunity to follow over 500 patients aged 50 to 75 years of age in a period of time that was anywhere from 3 to 6 years. What did they find? They found out that punctate lesions did not progress. And looking back at their data, they thought that they had initially misinterpreted these abnormalities as white matter lesions, when in reality they were perivascular spaces. What they found out is confluent lesions do progress, and the predictors of progression are advancing age and underlying hypertension. Here's a patient from our institution in a 10-year interval, and on the image on the left, you can see maybe one white matter abnormality on the left side. But 10 years later, in this hypertensive patient, you see multiple now severe confluent white matter abnormalities, and at the same time, there is now prominence of the CSF containing spaces, implying that there has been some atrophy or loss of volume of the brain. Now, the last thing that I want to mention is this entity that you should not confuse with these white matter abnormalities that we've been talking about, and this is called ependymitis granularis. This is a patchy loss of the ependymma that lines the frontal horns of the lateral ventricles, leading to gliosis. You see it as you see it on the two FLAIR images. They are symmetrical, but many times slightly different in size. They are this high signal intensity cap-like abnormalities that occur just anterior and lateral to the frontal horns of the lateral ventricles. It is a normal finding. It does not need to be reported. In a very old article that Gordon Seff from Yale wrote, he has a very nice pathology picture. Here labeled LV, you have the frontal horn of the lateral ventricle. CC is your corpus callosum. Here's the head of the caudate nucleus. And just lateral and anterior to the frontal horn of the lateral ventricle, you see this loss of white matter cells and gliosis and some spongiotic changes, and that is why these things are bright on T2 and bright on FLAIR images. So with that, I want to finish the talk. What did we talk about? I'm sorry, there's a typo here. It should be, we mentioned at least 5 types of well-defined white matter diseases: multiple sclerosis, NMO, MOG, encephalomyelitis, neurofascian disease that we said in 10% of patients can be a combined disease affecting both the peripheral and the central nervous system, and MDA receptor encephalitis. There'll probably be more in the future. Remember, we will not talk about ADEM, that is a disease of children. And then in the last 15 minutes or so, we spent some time talking about these white matter changes that we see in adults. We said they're very common. Their nomenclature tends to be confusing, and they can be progressive and need to be reported as such. So with that, I want to finish this part of the lecture. I don't know if I will go ahead and continue with the other part of the lecture, or should we take a break? Bart, please instruct us as to what to do.
Thank you, Mauricio. We have no break or no coffee break made during this online conference, so I hope you can go on with your next lecture now, if possible.
Yes, I will.
Okay, just take a coffee and then we can go on for the next lecture on emergency imaging in neuroradiology. Thank you, Mauricio.
Okay, let me go back. Hopefully, Bart, can everybody see my slides?
Yes.
Yes, okay. So all of us miss things while we're interpreting images. The rate of misses has not changed in many, many years, as we're going to see. We need to be aware of this. Fortunately, most of our misses tend to be insignificant, and there are some ways to avoid them. So I'm going to review some scenarios for common mistakes when you're looking at CT and MRI studies obtained in the emergency room. Take a look at the type of mistakes and try to see why they happen. Obviously, I would like to review some literature regarding this topic. I'm going to show you some examples of lesions that we have missed recently at our hospital. And for completeness sake, I do want to talk about how do we avoid or try to avoid these mistakes. So the most common emergency scenarios for ordering neuroimaging studies are patients that come in with stroke, headaches, altered mental status, and trauma. And at least in the US, 1 of every 14 patients that comes into the emergency room gets a head CT. That may have even changed recently. It's probably more than that now. If you look at the disagreements between interpretations of neuroimaging studies given by general radiologists versus neuroradiologists, we see that there is only a very small amount, 2% of disagreement. And the most commonly missed lesions were pituitary masses, so perhaps at least on an acute basis, these misses do not change the management of the patients. If we look at the rate of disagreements between radiology residents and neuroradiologists, it is also very small, 2%. However, the most commonly missed lesions by radiology residents in this study were hemorrhages and fractures, something that may change the acute management of the patients. But our radiology residents are doing very well. Now, if we look at the rate of disagreements between interpretations of neuroimaging emergency studies rendered by radiologists versus those ones rendered by emergency physicians who are not radiologists, the rate of disagreement is very, very high, 24%. And the most commonly missed lesions in this study were new infarcts, something that may change the emergency management of the patient. On the right hand of the slide, you see a small hematoma anterior to the brainstem that our residents missed on call. The next day, the attending came in, saw the hematoma, an angiogram was done, and that found a small aneurysm, which was later embolized. So this was a significant miss with one of our residents. What are the clinical consequences of this misses or misinterpretations among radiologists? Here's a study published in the AJNR in the year 2000, and they discovered that the clinical consequences were minimal. Out of nearly 2,400 patients, a change in management occurred in only 3 of these patients, so very, very few patients. If we take a look at a second study published a little bit more recently in the Journal of the American College of Radiology, the disagreements in the interpretation of head CTs led to a less than 1% changes in the management of the patient. So again, the disagreements are very, very few and lead to changes in management of patients in a very, very small percentage of patients. Here's an interesting article that comes from Israel. What they did is they did a retrospective study in nearly 1,000 head trauma CTs interpreted by the residents, and they try to see what was missed and where would these lesions miss. It's interesting to note that the highest number of misses occur between 2 p.m. and 8 p.m., the time of the afternoon and the evening. And they said that this happened because that is the time that they had the most work at their hospital. The lowest rate of misses occur from midnight to 8 a.m. because they had lesser amount of work. This is a little bit different to what we've seen, at least at my hospital, where the highest number of misses is in the period of midnight to 8 a.m. It's very busy. Our residents are tired, and we don't have attending radiologists in the emergency room to help them. As expected in this study from Israel, most misses and most false positive interpretations were rendered by the first-year residents, and less errors were made not by the fourth-year residents, but curiously by the third-year residents. If we look at where the findings were missed and what they were, we see that they were more commonly missed in the frontal lobes. The lesions most commonly missed in the frontal lobes were chronic infarcts. Lesions were also missed in the ethmoid sinuses, and that was mucosal thickening. And lesions were also missed in the basal ganglia, and those were chronic infarcts. So the presence of chronic infarcts and mucosal thickening are probably not important for the acute management of the patient. So probably these misses were not significant for the patient's acute management. And on the bar graph on the right hand of the slide, you can see that again, the lesser number of cardinal mistakes, misinterpretations, and false positives occur with the third-year residents. I don't know why it did not occur with the fourth-year residents. Okay, so if we make mistakes, what kind of mistakes and errors are we making? Well, we can make errors of interpretation. Those are lesions that are detected or seen but are misinterpreted. From an article published last year in the AJNR, on the first row of images, you can see a lesion that is dark on the susceptibility weighted imaging, and because of that, it was called a cavernous malformation. However, following gadolinium enhancement, there's a lot of enhancement, and we know that cavernous malformations show no or very little enhancement. An angiogram was done, and this showed it to be a peripheral infectious aneurysm. Second type of mistake that we make is an error or perception where the lesions are not seen. And here is such a case from that article. There is a small aneurysm from the medial face of the right internal carotid artery, which is there on the angiogram. And we know, and I know you know, that this is a very hard area to look at, and that not uncommonly we miss this very small aneurysms located just at the junction of the cavernous and supraclinoid internal carotid artery. So let me start now with the first case of something that was seen but misinterpreted at our institution. So an error of interpretation. Patient comes in with trauma, some basal ganglionic hematoma on the right. The residents interpret as probably the consequence of hypertension. However, the next day, patient gets worse and the CT gets repeated, and now the hematoma has expanded. There are hemorrhages in other parts of the brain, including the contralateral thalamus and the contralateral splenium of the corpus callosum. So now we know this was not a hypertensive hematoma. This was the so-called intermediary injury. So this is an error interpretation. And errors of interpretation may be done because of the wrong or incomplete clinical history, something that happens quite often at our hospital, working too fast, something that also happens quite often to us, distractions such as taking care of consults or answering the phone, something that also happens quite commonly to us, and in this case, the lack of knowledge of what is an intermediary injury. Here are examples of different intermediary injuries. On the left hand of the slide, a very large basal ganglia hematoma on the right side. On the central aspect of the slide, a ganglionic left-sided hematoma, which is a little bit smaller, but there's also a contralateral small thalamic intermediary injury. And on the right hand of the slide, not only do you see a small thalamic intermediary injury, but you see this very large bilateral basal ganglia hematomas, and many times this intermediary injuries as seen in this patient will have fluid levels. So that should really put intermediary injuries. Why is it important to make the diagnosis? These patients often have a terrible prognosis and they have lesions elsewhere, even if you don't see them initially. They are due to shearing of the lenticulostriate and thalamoperforating arteries, and that's why you have, as in this patient, these ganglionic hematomas and thalamic hematomas. And as I said before, they have a very, very poor prognosis. So once that our residents knew this, they did not make the same mistake again. Here's another case that I took from the internet. You can see that they can be very, very subtle initially. In this child, the blue arrows point to tiny hemorrhages in the left basal ganglia. 24 hours later, now we see a significantly enlarged basal ganglionic hematoma. So pay very special attention to the deep gray matter structures on your initial images. What is the differential diagnosis? Since we teach our patients that the most common non-traumatic cause of a basal ganglionic hematoma is hypertension, they made that mistake. Here's a hypertensive hematoma involving the basal ganglia on the left. On the central aspect of the slide, you see another differential diagnosis, patient with deep venous thrombosis and a thalamic hemorrhage. And on the right hand of the slide, you see a right-sided ganglionic hematoma. But if you pay attention, there is a lobular hyperdense structure in the atrium or the ipsilateral ventricle. And if we give contrast, now you see the nidus in the medial aspect of the basal ganglionic hematoma. And you see that what was inside the ventricle is a venous aneurysm. So 3 differential diagnoses for deep gray matter hematomas: hypertension, thrombosis, and the presence of vascular malformations. Here's another case. After trauma, the resident saw this hyperdensity in the vertex anteriorly and misinterpreted as an artifact. The patient went ahead and got a head CT for a CTA. And on the top of the slides, you can see a lesion that crosses the midline. So it must be epidural in location. There is a big differential diagnosis, but in this case, an MR showed that it was a vertex epidural hematoma. So again, an error of interpretation. And sometimes errors of interpretation may be due to the fact that we have an inadequate technique, no multiplanar reformations, the wrong thickness, the wrong windows, or a lack of contrast material. Here's another epidural hematoma in the vertex crossing from side to side. They account for about less than 1% of all epidural hematomas. They're commonly associated to injuries to the superior sagittal sinus. And as in the previous case, you can do MR, but I think that if you do good sagittal reformations, you can clearly diagnose them. On this sagittal reformation, on the bottom of the slide, you can see clearly the biconvex shape of the epidural hematoma pointed by the red arrow. Here's a study that came from Boston a few years ago, published in the AJNR. They took a look at the utility and value of coronal reformations in acute head CT. What they found is that in about 14% of patients, the abnormalities were detected only on those coronal reformations, and that these coronal reformations were very helpful in the interpretation of findings in about 1/3 of the patients. So since this article came out, we do very thin section, not only coronal, but sagittal reformations in all of our patients that have head CTs for trauma. Here's another case, a child that comes into the ED. I think that if you look at the image on the left of the slide, you all can see what looks like a subdural blood collection, a hematoma. But I ask you, can you see the finding that makes a diagnosis on the view through the orbits on the central aspect of the slide? The residents did not see it. Can you see it? Here's a very small retinal hemorrhage, and that makes a diagnosis of intentional trauma or child abuse. So one of the most common errors of perception are the findings are not seen and they are missed. Now let me show you another case here. This is a patient that comes in after head trauma, and this is interpreted as scalp edema. Well, If you look at the axial images and the coronal reformation, it does not appear to be simple scalp edema. Yes, there is swelling of the skin and the subcutaneous fat, but there's something else surrounding the bone, the skull. And when you look carefully, there are areas that appear lobular of higher density, and there are areas that appear of lower density. So do you know what this is? This is a close or internal deglobing injury. And this was an interpretive error. Our residents did not know about this entity, so they interpreted as scalp swelling. But scalp swelling requires no treatment, and this type of deglobing injury requires drainage to avoid infection. Deglobing injuries can be of two types, open and closed. The open type, you don't have any skin, you see the muscles and everything underneath it. The closed type is, like in this case, the skin is intact. This is the so-called Morel-Laval lesion, and the musculoskeletal people are very well aware of this because it is a lesion that predominantly affects the lower extremities. It is due to a separation of hypodermis from the deep fascia. It creates a space that's filled with blood, lymph, and lobules of fat because it has been shearing of the vessels that supply blood to all of these areas. There is necrosis of the tissues that surround it, and they tend to become infected. So many times they will need to be drained. From the literature here, you can see also a common site in neuro, the lower posterior aspect of the back, the lumbosacral junction. The second most common type is the skull, like the one that I show you. But on the MRI on the bottom, you can see this typical lesion. It has fluid levels of different signal intensities. It has fat lobules within it. It has a very irregular margin in this patient that has a type, a chance type fracture. How do they happen? You are going to have, let me move this a little bit so I can see my slide. You are going to have a parallel displacement of the superficial fascia and the subcutaneous fat with respect to the deep fascia, and that leads to tearing of these blood vessels, creating a hematoma that may also contain other things such as fat. Because there has been tearing of these blood vessels, there is ischemia of all of the tissues that will surround this hematoma, and this ischemia will lead to infection in many of these cases, and they tend or they need to be drained. My slides don't want to advance. What's going on? Oh, there it is. Okay, so here's a study published in AJNR a while ago, and they took a look at what kind of mistakes are we making? Are we having perception or interpretation errors? It is an analysis over 250 studies, and what they found is that 75% of errors were the perception type. Errors were twice more commonly made by individuals with 5 years or less of experience. They were more common when interpreting MRI or CT. I think that's reasonable. We have so many images to take a look at in an MRI. And the most commonly misinterpreted lesions were significant for the patients that were infectious or inflammatory conditions and autoimmune disease of the brain. Okay, now let's take a look at an error of perception. Here's a patient that comes in with trauma. I'm showing you some views through the base of the skull on the left hand of the slide and a soft tissue brain window in the middle of the slide. And I don't think our residents had any problem making a diagnosis of diffuse post-traumatic cerebral hemorrhage. You can see it, but can you see the findings at the level of the base of the skull? Give you a few seconds there to take a look. Yes, you can see them. Air in the temporomandibular joints. That led to the ordering of a temporal bone CT the next day, in which you can see the so-called longitudinal fractures, autocapsule sparing bilaterally in this patient. So this was an error of perception. The residents did not see this finding. And have either temporary or permanent hearing loss. Here's an old article published in 1991 in the Gray Journal on the issue of air in the temporal mandibular joint fossas as a sign of an underlying temporal bone CT. What they found is that 20% of temporal bone fractures had air in their TMJs, and that the findings were bilateral in 3% of patients. So just keep this in mind when you're looking. Don't forget to look at the basal skull. Okay, talking about the basal skull, here's a very interesting case that happened a month or two ago. There's a diffusion weighted imaging, a T2 stir, a T1 fat suppressed image, and here we have a post-gadolinium fat suppressed image. I think that on the susceptibility weighted imaging through the base of the skull, most of the times we tend to not to look carefully at them. They're degraded by considerable artifacts from interfaces with error, in this case like dental work. Do you see anything on the central image? I don't know. Do you see anything on the gadolinium enhanced image? I don't know. But the abnormality is present on the diffusion weighted imaging, and it was missed. And this is a dissection of the, it's not the right, but it's the left internal carotid artery on this side. You see the semilunar abnormality that led to a dissection protocol the next day. And now you can beautifully see this intramural hematoma with its semilunar high signal intensity on the T2 fat suppressed and on the T1 fat suppressed image. The use of diffusion weighted images to diagnose dissections in the high portion of the cervical internal carotid artery was recently described in HANR. What they concluded was that in nearly 90% of patients, the abnormality could be seen on the diffusion weighted images. Here's a picture from their article showing you again the semilunar clot in the wall of the artery, and here's again the case that I show you, showing you very, very similar findings. So like I said before, despite the fact that we tend to ignore these abnormalities or we tend to ignore the bottom slices on the diffusion weighted images because they contain significant artifact, they also contain significant information, and you should not just disregard them. You should look carefully at them. Here's another case, typical patient that is immunosuppressed and comes into DED with fevers and complaining of headaches, and we get a sinus CT. Our residents look at the image on the left hand of the slide. Maxillary sinuses look completely clear. The fat around the sinuses looks clean. It's read as normal. Can you see the finding on the image on the right hand of the slide? Can you see the finding? Can you make it? Well, it's there. And in this case, it ended up being an ocular melanoma, so it's a perception error. They didn't see it, and something that perhaps will not acutely change the management of the patient, but will change the management of this type of patients. Now, I've been showing you mistakes that other people make, and in order to be honest, you know, I said before, we all make mistakes. I always said in my life, if you're not making mistakes, you're probably not working, or at least not working enough. And here's a mistake that I discovered that I made last year, but I just discovered the mistake last week. So this is a young man, 32 years of age. He comes in with right-sided neck pain and headaches. A CT of the cervical spine was done at a different institution. There was some minor congenital abnormality of the dens. Do you see anything on the CT? I wouldn't have called anything at that level, but I'm showing you the most important level. A patient comes to our place with continuing headaches and cervical spine pain. An MR was done. Here how the axial images, T2s were presented to us. Can you see the abnormality? I didn't see it, but 8 months later, the patient comes back, and now the patient has a very large nasopharyngeal carcinoma extending into the pterygopalatine fossa, the clivus, the carotid space, and it was going up into the cavernous sinus and even involving the trigeminal nerve intracranial. You see all this gadolinium enhancement. You go back and you see that the abnormality is present here, a mass of low single intensity. And if you pay attention here, the slight asymmetry with obliteration of the fossa, Rosen-Mueller. I don't know that I ever would have called that, but I do feel terrible having missed this finding, so a perception error. So here's an article published many years ago in the Yellow Journal, AJR, about perceptual errors, and the same author, who is a malpractice lawyer and a radiologist, wrote another article many years later, And what he found is that the rate of perceptual errors has not changed in 50 years, and that we're missing findings in about 4% of imaging studies. So I think about myself, you know, when we are in our heavy rotation, which is our brain reading room, we read about 100 studies a day. It's very scary to think that I'm probably missing 4 findings on a daily basis. Hopefully most of them will not be clinically significant for the patient. Well, what do you do when you have a finding that is important for the management of the patient? Well, you need to immediately make your clinical colleagues aware of it. And what is generally done in academic institutions is having the emergency room for the residents what we call a list of critical findings. Studies published in AJNR in 2013 found that only 40% of all academic radiology programs had a list of critical findings, and a study that looked at what was included in this list found that the most common entities included in this list are hemorrhage, stroke, herniation, hydrocephalus, vascular malformations and aneurysms, masses, meningitis, abscess, and edema. I think that the most important thing about these lists is that they need to be short. If you make a list of 20 or 30 entities, your residents are not going to use them. They become impractical. And remember that the residents generally have lists of critical findings that need to be reported, not only from the brain side, but they have the spine, they have the chest, they have the abdomen. So like most checklists, they need to be fairly short if you want to assure that they will be used. Okay, we're coming to the end of the talk. So what are the potential solutions to avoiding errors? Well, education, have a feedback system. I think radiology, pathology correlations are very important. Some type of peer review. At our institution, every Tuesday, we show interesting and difficult cases and also mistake cases. We talk about them very openly. I think that it's terrible to make a mistake, but it's even worse if you make a mistake from which you and your colleagues cannot learn. If it is a mistake that it's applicable on a system-wide basis, we flag that case and it is discussed at our morbidity, mortality, and improvement conference once a month. Other things that you can do is good technique, at least like I said, in your emergency head CTs, coronal and sagittal thin slice reformations. Minimize distractions, have somebody in charge of answering the phone or fielding consultations while the other people are working. Supervise your trainees. In the US, no trainee, whether it's a resident or a fellow, can dictate by themselves. Structure reports tend to be very helpful, particularly for the younger people. They teach them how to think. Align your workload with realistic benchmarks. I think that realistically one can read about 60 brain studies a day. More than that is, you know, it's too much for me. And maybe it's because I'm getting older. But at our place, we read way too many. Artificial intelligence, will it be helpful? I think it will be helpful. It may not tell you what the finding is, but it will tell you where the finding is for you to look at it, and it will place that study on the top of your list so you can look at that very fast. How about double readings? They are a little bit controversial. There is not a lot of literature about it out there. Here's an article that was published a couple of years ago. What all of these articles conclude is that yes, double readings increase the quality of a report, but there is a very high rate of discrepancies in this study. The discrepancies occur in up to 22% of reports. So you end up with a lot of reports that need discussion, and that takes a lot of time. These authors suggested that double readings are better for targeted high-risk examination. That means that you must know at your institution what the high-risk examinations are. I don't know what the high-risk examinations are at our institution. It seems that when we make a mistake, they tend to be all over the place. Okay, so we come to the end of the lecture. How can we minimize the number of errors that we make? As I said, a good environment in the reading room that avoids distractions. We have now what we call reading room assistants, and they are in charge of answering the phone. And if there's something that they can answer themselves, then they will take care of that, and they will just pass along to the reading room the phone calls that have to be answered by physicians. We have 2 reading room assistants for all of our department. Some very, very busy academic hospitals, each division will have its own reading room system. Avoid fatigue by reading the appropriate number of cases, have some kind of peer review case evaluation. As I said before, if you cannot have structured reports, even macros are helpful. Supervise your trainees. We talk about artificial intelligence. And obviously, to avoid errors of communication, which tend to happen, have a short list of neuroimaging critical findings. At our institution, our policy is that these critical findings must be communicated within 15 minutes to the emergency room. They are communicated by telephone. They are communicated in the electronic medical record or both, and they are documented in the report. We state the time that we spoke to that clinician and the name of the clinician that we spoke to in those report. And remember, if you have this very long list, paradoxically, they become unusable and they're no longer practical. So you should have them available at all times, but they should be short. And with that, I want to finish the lecture. Thank Bart Kleikens very much, and thank all of you for joining us and listening to the lectures this afternoon. I don't know what to do now. You tell me what to do.
Thank you very much, Maurizio, for your great state-of-the-art lectures on inflammatory diseases and emergency imaging. It was a great talk, as we used to have from you. I do hope we can organize a conference next year, and we will welcome you then in Bruges, in Belgium, to give you a wonderful time there, Maurizio. Please stay tuned so you can have some Q&As at the end of the lectures, and then we talk again. Okay,
I will be here. Thank you.
Dear attendees, if you have any questions, please use the dedicated box to send them to us so we can give them to our faculty members. And now we have back Professor Kesselman from St. John's Hospital in Bruges here. We arranged some technical issues, and I hope we will go on now. Good luck, Jan, and thank you for giving this lecture, and I give you the floor. It's up to you, Jan. Thank you.
Okay, Bart, thank you. Can you see my screen now?
Yes.
Yes, okay. So there we go. I'm sorry for the technical problems we had. They told me I was kicked out at the level of the first movie, so we try it. Can you see the movie now? Can you see the movie? Okay, so here we see that we are looking at black blood images, and the black blood images without and with compressed sense. And you see, if we are using the compressed sense imaging, then we have exactly the same quality, but we gain a lot of time. That's the same if you would go for higher resolution at the skull base. That's the same if you would go for the brain. You gain a lot of time, and it's necessary because otherwise the sequences are too long. Now, in our experience, clinicians love this sequence, and they actually ask immediately for the new applications, especially metastasis, so you don't have to advertise it. And we're still discovering new applications, and we replaced in many applications already the 3D T1 weighted sequence with gadolinium. And you see there's already a lot of possibilities to use that sequence. In the brain, of course, that's the number one, but also around the brain in the skull base area. Now here you see an example of a patient with metastasis and you see that we have a lot of metastasis. On the T1 you see them, and also on the black blood. So first of all you say, okay, there's no difference. But if you start analyzing the images, then you see here, the first on the T1, we thought that was a vessel. Actually, it's a metastasis. Here we saw the metastasis on both sequences, but on the black blood, we see meningeal enhancement, leptomeningeal, which is invisible on the T1. And here we thought it was a vessel, and once again, we see it's a metastasis. So you see it's much more sensitive, and it gets all the little things out. Another thing is that you're not only looking at the metastasis, but also at meningeal metastasis. And here what you see is actually that on T1, you always see all the meninges. However, on black blood, you don't see normal meninges. You only see them when they are thickened and abnormal. So this is meningeal metastasis, which you can see and which is not visible on the T1 weighted sequence. So this is what you are looking for, and it's selective. It only shows you abnormal meninges. Another advantage of black blood imaging is that it's more sensitive for enhancement. Here we have cervix carcinoma metastasis, 1, 2, 3, 4 on 2 slices. And look, on the T1 with gadolinium, no enhancement at all. So it's very, very sensitive to pick that up. And that's for several tumors. Here we have a ganglioglioma. Look on the T1 with gado, a little enhancement. Look on your black blood. You can't miss that. That is very strong enhancement. Maybe we can save gadolinium as well if it's that strongly enhancing. Even for recurrent disease, this was a patient that had a surgery for glioblastoma. We were looking for recurrent disease. And here in the hippocampus on the left side, you see on the black blood, we see the enhancement. On the T1, nothing. You wouldn't have picked it up. So this is one of the reasons we are using black blood all the time. Another example, this is a glioblastoma growing into the ventricle at the level of the splenium. Now, what do we see? Well, we see actually on T1, nothing. Look here at the temporal area. But if we are going to look further down, nothing. But if you look on the black blood, you see the ependymal enhancement. And there was already invasion and further extension along the ependym in the whole lateral ventricle on the right side. So these are the kind of things that you pick up very, very easily. And it can be very frightening. This patient had breast carcinoma, had known metastasis already in the spine, and now she comes for brain metastasis. And you see that she had a CT scan, and you see the bone was normal. On T2, I think you call that normal. On T1, we know we see these kinds of enhancements in the bone. But look on the black blood. These are all metastases. Same in the cervical spine. And we didn't pick them up with any other technique. And even on the CT scan in the spine, you don't see the holes in the bone. So there's a lot of sensitivity there that we can pick up. Not only for tumors, but also for demyelination. Here we see the 3D flare, which we use routinely to look at white matter diseases. Here we are looking at infarctions. Well, you can see them on T1 as well, if you window it right. So it has the potential to show better the enhancement, but also to show the white matter lesions, and in a very detailed way because they are very high resolution. And here you have an example of pseudotumoral MS. And you see that the MS lesions are enhancing at the back on T1, but look on the black blood, you can't miss them. And that lesion here at the front is not enhancing at all. It's not active. Yes, it is. It is active if you are looking on the black blood imaging. Here another example, MS patient, negative. We think these are flow artifacts, low signal intensity. Look at the black blood with GAO. Also, if you look outside the skull, because today in many cases you see the cervical medulla, and here we have the T1, no enhancement. Look, there we have an enhancing lesion on the black blood. So this is an active MS lesion, which would have completely missed without the black blood sequence. Also meningeal enhancement. We see more and more cases where in MS we see meningeal enhancement. So inflammatory localization that was published. You can have them in the deeper meninges, on the surface meninges, and we couldn't see that on flare or flare with gadolinium and subtraction before and after gadolinium. But now on black blood we see them. And you see here the patient is losing the enhancement on the follow-up examination. And I can show you another example here. We have 10, 20 of them like that already. You see that we have multiple sclerosis. Here we see in August 2018, the patient has enhancement on the meninges, left frontal. In October, it's gone. No enhancement at the 2 levels. And then the patient comes back in August 2019, and now he has MS lesions with edema, with inflammation on the meninges on the right side. And okay, retrospectively, maybe you say that's thicker, but I challenge you, nobody will call that abnormal meninges if you just have the T1 with gadolinium. So this is really changing the game, and we are using that all the time, also in vascular problems. So here we have a young child, 7 years, that comes in with an infarction, and you see that the carotid has closed down, but you also see that something's wrong here with the medial cerebral artery, and there are no branches to the back. So what's going on there? So we checked it, and first of all, we saw on the unenhanced, because here you need unenhanced and enhanced black blood, that there is a little thicker wall, and look, it's enhancing after gadolinium. And further on, if we look higher up into the brain, you see here in the central sulcus that we have, this is enlarged here, you see that we have the normal vessels without gadolinium, the black blood, and after gadolinium, you see the walls enhancing. This is vasculitis. And in the center, you still see the flowing blood after gadolinium. So for the first time, we have this very subtle way to look at the vessel walls, because in the centrum, we have no gadolinium in the flowing blood, but it's black. Also for aneurysms, it's very interesting. This is a patient with multiple aneurysms. She's followed. And here you see that we have one aneurysm before, after gadolinium, before, after gadolinium, nothing changes. But you can also have other ones. Look at this one. This is an aneurysm here, and you see that the wall is enhancing. So this is an inflammation of the wall. This is the aneurysm at risk that could rupture. And here you see another example, the same, sorry, in the coronal plane, with gadolinium. Look at the wall enhancing. And here we have another one on the media, no enhancement, and after gadolinium, the walls. So these are the two dangerous ones that probably should be treated first. So this is very interesting. Another example of a lesion that turned out to be an aneurysm. In an outside hospital, they saw a lesion, and the differential diagnosis was schwannoma, aneurysm, meningioma. But you see on T1 low signal, on T1, on T2 high signal in the axial plane, and here after gadolinium enhancing. What is it? We did high resolution MRI on the 3 Tesla system, and you see it is weakly filling. So it's an aneurysm, but only a little bit of flow. And what is interesting, if you look at the coronal T1 weighted images, you could still doubt if that is not, there's no dural table, it could still be schwannoma. But if we are looking at the black blood, look what you have. This is the flow after gadolinium in the carotid, and this is the neck of the aneurysm and the open part of the aneurysm, and this is the thrombus in the wall, and this is the turbulence higher up in the aneurysm. So you really have a fantastic, without artifacts in that area, because there's no susceptibility, it's a turbospin echo, so you can see these changes. Also in fistulas, you can look for the flow. This is a patient that had a carotid cavernous fistula on both sides. On the T1, not a lot is seen, a little bit there, flow. But of course, on the MR angiography without gadolinium, you see the high flow in the cavernous sinus and the plexus basilaris. But look what you can see on the black blood. The black blood shows you the carotid, but look at all these black spots. This is high flow in the sinus because of the fistula, high flow at the back in the plexus basilaris. And in the coronal reconstructed images, this is the carotid. This is all high flow, high flow, high flow, high flow in the cavernous sinus and at the back of the clivus. So you see, you can actually use it for this flow sensitivity as well. And finally, for vascular lesions, remember Sturge-Weber. You are always looking at the meninges, the leptomeninges, where you have the vascular malformation. This is T1 gadolinium 3D and the flare. You can see a little bit. Look what you have on the SVI and look what you have on the black blood with gadolinium. You see all the meninges with the abnormal vessels enhancing, and you know exactly how extended the disease is. So you see it's very sensitive. Also in inflammation and infection, we can use it. And what you see here is a young child, 11 years, came back from North Africa from vacation and fell. Vertigo, just fell over. So was admitted, and we did CT scan, negative. We did MR, all sequences negative. Finally, we did the new black blood sequence, and you see that supratentorial, all the meninges are okay. But look, infratentorial, we see all the leptomeninges enhancing. So this is cerebrolitis because of a viral infection. They finally took CSF with lumbar puncture, and everything was confirmed. And you see, even in retrospect, it's very difficult on T1 to say something's going on, because very often you have harder or stronger enhancement of vessels in these children. This is a patient with varicella meningitis, had headache, fever, knuckle rigidity. So once again, we were looking for meningeal enhancement, but we were surprised that the varicella meningitis probably caused thrombosis, and not thrombosis, actually, it's phlebitis, because this is black blood with gadolinium. You see the wall enhanced, but without gadolinium, there's still flow in the center, but less dark than in the normal cortical veins. On T1, you can't see it. On black blood, on the SVI, sorry, you can't see it. On the flare retrospect, we found this. And you can see here the wall enhancing of the veins. And so it's a very, very sensitive technique to look for thrombosis in the cortical veins or thrombophlebitis in these cortical veins. So this is another application that you can use it for. In trauma, well, you can of course see the meningeal enhancement, but also if you have a subdural chronic hematoma, it's obvious because the meninges are so easily visible, it's much easier to see the subdural hematomas than you can see on T1 or T1 with gadolinium, as you see here. Then we come to some interesting points that show you how sensitive it all is. This is a patient with Sussex syndrome. This is a microvascular disease that affects eye, ears, but also the brain vessels. And on T1, everything is negative. But look, all these leptomeninges are enhancing, and there are parenchymal enhancements, probably around small vessels. And you can see all these changes happening. So we see what's going on, what is invisible if you are using routine, even high resolution T1 with gadolinium. And of course, the typical changes of the Sussex were also seen in the corpus callosum. Then there's another point again, just like in the vessels, we also see CSF flow. Now, this is a patient with NPH. You see the big ventricles, you see the high flow in the aqueduct, but to the third and fourth ventricle, we see high signal again. But look at the black blood. This is a normal ventricle, but this is very high flow, very high flow. And look how we can see that already on the sagittal image. So also for the flow in the CSF, it's a fantastic sequence. Now, we can use compressed sense to speed it up, and we need that especially if we go to a high resolution. And we will need that if we are looking at orbit, temporal bone, pituitary gland. Now, here you see a patient with optic neuritis. Look at the T1. We were thinking, is that something or a vessel? In the coronal plane, nothing was visible, but look on your black blood. On the black blood, we see the enhancement very clearly. So once again there, for neuritis, it's much better. And even for perineuritis, here we see perineuritis stopping halfway the orbit. And you can see that in the coronal plane. Look at the optic nerve further anteriorly, there it's gone. You can see that really, really in detail, while all the other sequences stay negative. So it's very sensitive also for the veins. Here we have a phlebitis of the frontal vein and the superior orbital vein. You see it coming from the frontal area, see the wall enhancing, but the center, there's still flow. And you see it here at the back and the apex. If you look at the other side, here you have the normal vein. Now look at your T1, nothing. It looks completely normal. You can't even see there's a thrombosis. And on T2, it's a little bit higher signal, but who will call that a thrombophlebitis of a thrombus? So you see the sensitivity of that sequence is very high. Even for tumors, here we have a meningioma going into the orbit like a tram track sign, and you see that we have no artifacts, high resolution, and the meningioma is on the superior surface of the nerve. And here you can see the squeezing of the nerve with the meningioma around it. And this is a technique that we now routinely use for orbital lesions. Here we have a lesion in the orbit, visual loss on the left side. In the optic canal is pushing on the optic nerve. And what do we see? Well, we actually see it on the T1, on the T2 with high signal, but on the T1 after gadolinium with fat sat, I can't see it. Maybe without gadolinium, there you see the fat disappearing a little bit, but I can hardly see it. This is black blood. This is how the nerve looks like in the coronal plane. Look at the sheet and the central part. And here you see that we are dealing with a beautifully enhancing lesion we couldn't see on T1, and there it is, and you see exactly, you can measure it, and it turned out to be a cavernous hemangioma in the optic canal. So very, very sensitive. Also in the temporal bone. This is what we did in the past. We looked for T1, 3D, and you see a schwannoma on very thin images, and you think you saw the reality, but we have susceptibility. If you do that on a turbospan echo with black blood and gadolinium, it looks far more round and bigger. And this is how we can look now today at these schwannomas. Also, if you have schwannomas in the labyrinth, here you see the fluid in the labyrinth, there it's gone because we have a schwannoma. Look how you can see it on the T1. Look at the same level on the black blood. It's much more obvious. You see better the extension in the vestibule, which is visible, but look how more beautiful and detailed you get the results. And the same goes for labyrinthitis. Here we have a patient with labyrinthitis on the left side. Have a look. T1, completely negative. If I look on the images with flare, it's enhancing. If I look on my images with black blood, it's enhancing, and I can see the different scalae because I even have the high resolution. And there is no schwannoma because we still have normal fluid on the T2. So T1 negative, black blood shows you labyrinthitis, and better and more detailed than you can even see with the 3D flare. The same goes for neuritis of the facial nerve. Here we have neuritis of the facial nerve, was difficult even on T1, and the advantage is that once you are in the tympanic and mastoid segment, which you see here, normally there are 50% of the space in the canal is filled with vessels, and they can enhance as well and fool you on T1, but not on black blood, because on black blood these vessels are black. So if you see enhancement, that's the nerve you see enhancing. So that's a big advantage over what you would see on a T1 weighted sequence. And finally, we come also to the pituitary gland. The pituitary gland has always been the most challenging structure. It's very small, and it's in the center, farthest away from the coils. So you need signal, and you want to have it in 3D. Nobody's using 3D today. So you can do that with black blood. And once again, you need, of course, compressed sense, because otherwise you run in times that are too big. Now we run that in about 6 minutes. So here you see an example, T2, high signal, T1 without, T1 with gadolinium, the dynamic, that's obvious, there's a lesion. This is 3D imaging, one sequence, and you have all of it. You see it in the coronal plane, the sagittal plane, and the axial plane, but that's easy. Now here we come to a little bit more difficult situation. We see a little lower signal on T2, maybe on the dynamic, T1 is completely negative, sagittal, we couldn't see it. Now we go, after that, we try to see that on our black blood. And if you go to the black blood, look, this is the pituitary stalk, that's 3D imaging. And here you see there, oops, you see it, the round lesion, that is our microadenoma. On the coronal reconstructions, look here on the left side, that's my microadenoma. And there I see it in the sagittal plane. Whoops, here it's okay. And there comes the microadenoma, whoops, at the back. So you can start seeing very small lesions. Another one, you see the pituitary on T1 gado, T2, okay, it's asymmetric, but where is this one? Where is the adenoma? We can't see it. Well, have a look here. No problem. There it is. 5.4 millimeter, and we reconstruct it in the 3 planes. So that's the way we can look at these pituitary adenomas today. Then for the skull base, of course, at the skull base, you have several problems with air, bone, and brain and fluid interfaces. So it's always a problem. And on T1, 3D, where you want the thin slices through the bone, is always a problem. So what's that? Is that normal? Is that more marrow in the bone? Well, here you see actually that on the black blood sequence, you can't miss it. This is all metastasis from a prostate carcinoma. And here we have a fibrous dysplasia that grew very fast in a 10-year-old boy. It was that big a year before. In 1 year time, that grew that much and pushed away the brain. Look on the T2, we thought that's fluid. Okay, then on T1, we thought maybe it's blood. So, but on T1, it is not hyperintense. And then after gadolinium, it's not enhancing. That's what you think. But that superficial, fast-growing fibrous dysplasia is enhancing, but you can only see it on the black blood. The other ones are not sensitive enough to show you that. So you see, it is really a fascinating new way of looking at how everything is evolving. And here you see that all around that fast-growing fibrous dysplasia, we have the enhancing changes in the bone that is growing that fast. Finally, one example here of a chondrosarcoma at the skull base. And here you see that at the skull base, we have the T1 weighted images. These are 3 to 4 millimeter thick. They are beautiful, but you don't have the details, and they take very long. Here we have one black blood sequence, and you will see that on the black blood sequence, we have the high signal and the high resolution. So here you have the movie, you see the chondrosarcoma, you see it going in the posterior fossa, you see it going in the internal auditory canal, it's following the nerves in the jugular foramen, and then it follows the nerve in the post-styloid parapharyngeal space under the skull base. And you can just reconstruct that in any plane. Look at the details of the internal auditory canal, everything is there. So it's a fascinating technique that has no susceptibility and is very sensitive to see enhancement. So in conclusion, black blood is a very sensitive sequence for gadolinium enhancement and shows you enhancements that you couldn't see before. Think of the MS of the meninges, think of the enhancement at the border of the tumor I just shown you. It's excellent to distinguish pathology from vessels. On 3D T1, you're always puzzled with all these enhancing vessels. You don't have them. The same goes for the meninges, because only the pathological meninges enhance. You can't see normal meninges enhance. And the vessel walls can be seen because the blood, even with gadolinium, remains black. So enhancement of the wall on pre-post black blood, you can see that and you can make the diagnosis of vasculitis. T1, it's a T1 sequence, so you have no susceptibility artifacts. That means that the skull base can be evaluated, and it shows fast flow in vessels, but also in NPH. It can be used in many anatomical regions, brain, orbit, T-bone, pituitary gland, which is fascinating, 3D imaging, and skull base. And it already replaces 3D T1 for many, many indications in our department during the last 3 years. And we are using less and less 3D T1 and more black blood. And I hope I have been able to show you why. And I think these examples show you that there is a real advantage. I thank you for your attention.
Thank you, Jan, for your fantastic lecture on black blood imaging, and it's promising a more than fascinating feature in neuroimaging. I kindly invite now all the faculty members to share their insight during a Q&A now. So I ask all the members or all the faculty members to activate their video and their audio. So everybody is online now, and we see everybody and we hear everybody, so that's fantastic. We get a lot of questions from the audience or for the virtual audience, let me say like that, and I picked some questions that I will ask the panel members or the faculty members for their reaction. I have one question for Professor van den Houwe, and it's by Jacques Widelec. So look, what's about Stir and T2 Dixon, which of one is more accurate for spinal lesions? So which of the two imaging sequences is most accurate for spinal lesions, the Stir or the 2T Dixon? Luc.
Good afternoon. Well, to answer your question, I think it depends on the way you're used to work and maybe also on the machine you're working with. So I have my most experience in the Antwerp University Hospital with Siemens, and it seems that Stir is a very robust sequence. You have very equal fat suppression over long with images with large field of view. But I can imagine that if you, like Jan Kasselman is working with Philips, I know that the Dixon technique is working very well. So I don't think that Stir is the only sequence you can use. What you need is a T2 weighted sequence with a very robust fat saturation.
Okay, thank you, Luc. I have a question for Professor Castillo. Professor, in inflammatory disease, is if the inflammatory disease is treated sufficiently, does the SWY rim finally goes away on later follow-up imaging? Professor Castillo?
I don't know. I don't have an answer for that. I don't know if it goes away. Maybe John or Luke or Bert will have experience on that. I don't have experience whether it goes away or not. No. I'm not familiar with.
I was saying I don't know. Sorry.
Okay, no comment on that. So it's maybe a thing to follow up there. I have another question on the talk of Maurizio. The teratomas that may lead to encephalitis, are they benign, mature, or malignant, or both?
I think both of them. All of them have been reported, particularly the malignant ones, to be associated with the NMDA receptor encephalitis. It's overall, it's a very uncommon disease. I don't know if anybody in the audience has much more experience than I do, but we see very little encephalitis on a paraneoplastic basis, and we see very little myelitis on a paraneoplastic basis. Very, very rare. And most of our cases, at least at our institution, differ a little bit. Most of our cases that we have seen come from carcinoma alone rather than the teratoma in the abdomen.
Okay, thank you. We have another question here for the talk of Professor Castillo. In what age group is Hidradenitis granularis physiologic? In young adults, or is there a differential diagnosis in younger individuals?
Bart, can you repeat the question, please?
So in what age group is epididymitis granularis physiological?
Oh, it's physiological in everybody. No, it's always a physiological lesion. It's an expected finding. It does become a little bit more prominent as we get old, and people used to say in the past, as we get old, the pulsations of CSF start compressing your ependema and wearing down your ependema, and that leads to this changes around the frontal horns. But it is, you can find it at any age. It's always physiological.
Okay, thank you, Mauricio. I have then some questions for the talks of Professor Kasselman. What's the Siemens equivalent name for 3D brain view black blood imaging?
They call it black blood as well. They have it. They actually started with a slab, but I think for the moment they already have the black blood sequence. So the exact name, as far as they told me, because we discussed it, do you have it available today? They have it available, but it's only on the newest software that you will be able to do the complete brain. As far as I know, they first only delivered a slab. So you could do, for instance, only the supertentorial and infratentorial part. It's called black blood. But as far as I know, and I heard recently, they have it now available for the full brain. And it's called black blood.
Okay, thank you, Jan. I have another question here coming up. Sorry.
If I may comment, the sequence that we use in the Antwerp University Hospital is a 3D space sequence with the Dante prepul. So the name of the sequence is the 3D Dante space.
Any other comments on this question or advices?
And is it a complete brain now they deliver? Look.
It is a complete brain. It covers the complete brain.
I have another question here coming up about black blood imaging. Is it available in the future on 1.5 Tesla, or is it really impossible?
I think it is no problem to do that on a 1.5 Tesla as long as you stay in the brain. As you've seen there, we go 0.8 millimeter. Of course, your signal will be a bit lower, but for routine brain, that would not be a problem. I think if you want to go, for instance, to go to the pituitary gland, that's another story, because I think there you really need a signal, or you come up with sequences that go up to 15 minutes, and that's not realistic anymore, also for movement artifacts. So that's more a problem. But I think for the brain, and that's the majority of the applications, I think that should not be a problem.
So what we have noticed doing our high resolution vessel wall imaging, we don't call it black blood because of political things. We don't call it black blood. We call it high resolution vessel wall imaging. Is that on the on the 1.5 on the slab, the CSF does not suppress as much as I don't know. It must be something in our magnets, which they're Siemens. It does not suppress as much as you would see on the 3 Tesla. It's a little grayish, as you said, John. The resolution's a little grainier. It's still diagnostic, I think. You can still see vessel wall enhancement and enhancement of subarachnoid space. We're working in the old-fashioned way. We're just doing a slab through the area of interest still. So, and mostly what we haven't used it. I'm amazed and very impressed by those images of the cranial nerves and the orbits. We've used it for vasculitis and for aneurysm imaging, basically. But after this lecture, I'm going to start using it for cranial nerve imaging. It's fantastic, yeah.
Okay, I have another question on the blood imaging. Is the intracranial hemorrhages or the intracranial hemoglobin still bright on T1?
Yes, it is.
It is.
Yes, it is. Blood you will see, as you saw in the case with the aneurysm, where we saw the neck open, you could see the thrombus in the wall, and it's white.
Then I have coming up another question. Have you encountered in blood imaging any problems with too much sensitivity, for example, exceeding the size of the schwannoma in the labyrinth?
No, we've not seen that. Of course, you have to window your images, and your threshold is changing because what we called in the past active MS lesions, that's now different. There are more active than we saw before. So we have to have a new reference set of what is enhancement and not enhancement. Also, for instance, in infarctions, we see that infarctions that are enhancing, it's unbelievable. In the past, you could hardly see them enhancing, and now they're completely white. So the windowing has to be adapted. If you stay with the old windowing, it will be burned, and you can't see through the lesion, and then it looks too big. But if you adapt your windowing, there's no problem at all. It will stay within the cochlea. It stay within, but it's beautiful round. And I'm really convinced, because if you compare it with the T2 weighted like Drive or Fiesta, it has the same size on the black blood, and it's the T1 that's different. And the T1 is different because you want slices and you have susceptibility. It's a susceptibility that makes it look different. it deforms a little bit your anatomy. But if you stay in turbospan echo, that's more stable, and you don't have the susceptibility, and that's why it looks bigger, but it's not bigger, it's the reality.
Any other comments on this question?
I have a question for John. We've done some cases of vasculitis in which you don't see anything postgadolinium on your regular T1s, but once you do the vessel wall imaging, subarachnoid space enhances diffusely.
Yep.
Yep. I don't know what the explanation for that is. And the other question is, I know that you don't have a lot of tropical brain infections, but I thought about, cysticercosis, which we do have a lot, and to see if, the lesions are enhancing or not, and the patients need treatment or retreatment. Do you have what experience do you have with both of those things, the vasculitis, CSF enhancement, and some infections?
Well, for the infections, it's clear it's enhancing much better. So you will see it better, and you will see more lesions. Because it's there you really go for the sensitivity of the enhancement, and where the blood-brain barrier is disrupted, you will see it much better. A bigger problem, and I'm glad you pointed at that, is the differentiation. Is it the vessel wall that's enhancing, or are it the meninges around it in the meningeal space? And that's why I also showed you the case of the Sussex syndrome. Because in that case, probably what you are looking at are the meninges and the Virchow-Robin spaces that you see deep in the brain that are enhancing. And that's always the big problem. But if you see a vascular, like in the child, it was a definite vascular disease, then you know it's a vascular wall, and it stops normally, then it also stops around the vessel. If you see that it's a leptomeningeal that is also involved, which is really in contact with these small vessels, then most often you see it further along the road. It's not stopping at the wall of the vessel. You can follow it further in the sulcus, most often. But in some cases where it's very tiny, I agree with you, sometimes you can't tell. And then you really have to say, okay, there's an enhancement. This can be vasculitis, but this can also be meningitis, leptomeningitis, in the deep spaces, Virchow-Robin spaces, where you take the little leptomeninges with you.
So another thing that I think is initially when we started doing the vessel wall imaging, we equated enhancement of the wall with inflammation and vasculitis. But the more you do atherosclerotic patients, you do patients with sickle cell and moya, you do patients with neurofibromatosis, you see a lot of vessel wall enhancement. So I think that, just using vessel wall enhancements as the sine qua non of vasculitis is perhaps a mistake.
I completely agree with you, because we had the same problem with one lesion in a young patient that did posterior fossa infarctions, and the wall again was enhancing. And then the big problem is that ateromatosis, which I thought it was sclerotic disease and not vasculitis. Now, one of the things that we always do now is black blood before and after. Because you cannot say something's enhancing if you don't have the ones before. That was a mistake we made in the beginning. We only looked after when we say, hey, there's a vessel enhancer, but now you look before, if there's already a slight hyperintensity or not, if there's a dissection, if it's a plaque with some blood in it, and that makes a big difference. And so I think it's an obligation to do it before and after. Otherwise, you should not comment on it.
Yeah, this is the same situation when we used to do postgadolinium flares, that you have to get them before and after the administration of contrasts.
Okay, thank you. I have another question coming up here about black blood imaging. It's about the next question is, in which cases do you prefer the T1 FFE sequence rather than black blood imaging?
That's a good question. There are some very specific cases, and one of the cases I love to do is in, for instance, when it's a meningioma. When you have a meningioma that is abutting the sinuses, you want to see the sinus, you want to see the sinus wall and the bone. And on the black blood, that's more difficult to see. So that's what the surgeon wants to know. So for me, meningiomas, it is always with T1, with gadolinium. And then also when you are looking at bony walls, if you are looking at the neuroforamina at the skull base, and that's important, then you should go for a T1 as well, because the black blood also, as you see, it's a kind of T2 looking sequence. You lose the marrow in the bone, So it's only when it's enhancing that you can see it better. But if it's not enhancing and you need your anatomical references at the skull base, then you should have a T1. You should not go for the black blood alone. So there you cannot replace this. It is an additional sequence. That's different from all the cases I've shown you where we actually replace today the T1. The first 2 years we run it side by side so that we knew exactly where it was better, where we could miss it and could not miss it. But like meningioma is a typical one. If you want to see thrombosis, we still do it. If we're still looking for a thrombosis of the sigmoid sinus and so on, I will still use my T1 with Gado to see if there is an absence of the enhancement in the vessel, because once again, that's more difficult on black blood, although we learned in the beginning, we were afraid of it, that if you have thrombosis in a vessel wall, and especially when it gets inflamed, it is more sensitive, like the cortical vein I've shown you that was a thrombophlebitis. And we have also already several cortical thromboses that we actually could pick up only on the black blood. So there we are moving. In the beginning, I said, I still need my T1, and gradually we're learning, and we're moving also to the black blood. But for meningiomas, if you want to see bone and if you want to see invasion of the veins, then I would be very, very, very very careful to do that. Same thing if you want to look paracellular and you want to see the nerves, for instance, involvement with meningiomas. If it's involving the cavernous sinus and you want to see the nerves, black blood is not working there. That is the level, that is the area of T1. T1, especially in the coronal plane, there I would not use it. And that's the first ones I come upon, because these are the most frequent. There are some other instances we don't use it. But let's say in 70% of what we do in the brain today, we prefer black blood.
Okay, thank you, Jan, for this nice answer here. I have one last closing question for all the faculty members, and it's about the COVID-19 and the lesions, the changes, the features you see in neuroimaging. So tell the audience what you have experienced in these last months on neuroimaging and on that coronavirus.
Well, I can give one answer on that in my area. That's the olfactory bulb. So we get more and more people asking for measurements of the bulb in young people that have loss of smell and they do not recover. The majority is recovering after a couple of weeks and it goes fast. But some, after 3-4 weeks, they still have a complete loss of smell. And in these cases, they ask us, and we've seen so far, but the problem is you don't see these patients back. It's too early because you want to see, will they recover? But we've seen in some of these young patients volume loss. So the question is that just statistically, or will we be showing later on that they have a normal volume again? Because you know that the bulb, if you lose volume, if you train it, it will go up in volume again. So we have to wait for that. But anyway, we haven't seen any signal changes in the bulb. So on T2 weighted images, we haven't seen them becoming bright. But there is a real interest in that, and we get from all over the place, we get people asking, can you see something? Can you help these patients? But unfortunately, it remains today to volume measurement.
Any other comments or experiences?
Yeah, we have published 2 papers in the AJNR recently. One of them is showing patients that have PRESS-like findings, which, as you know, the ACE receptors are probably more common in the back of the brain, and maybe, I don't know, that has something to do with it. The second is just infarcts. And you know, all of the patients that get into the ICU nowadays get anticoagulated and have steroids in order to avoid the infarcts. But I think, you know, from following the literature, that the findings are all over the place. I think that you can get many manifestations in the brain that are completely non-specific. I think that the only thing specific is what Jan is saying, is the high signal intensity and enhancement of the olfactory bulbs bilaterally. COVID is the only thing I ever seen it. Perhaps it happens in other coronaviruses, but we've had cases that we know that we think this myelitis secondary to COVID, basal ganglion lesion secondary to COVID. There's no proof of it. It just happens when the patients are positive. I don't know. I have the idea that the findings are very non-specific, except for the olfactory bulbs.
Another thing that I heard from the neurologist, because unfortunately we don't see it in the radiology literature, but it seems that in the neurological literature, they see a lot of cranial nerve enhancement, several cranial nerves. So if you see multiple cranial nerve enhancement today, you should think of COVID.
I think that there's an article in AJNR that appeared this week from Doug Phillips in New York City about the cranial nerve enhancement. Yes.
Yep.
Okay, any other comments? Luc, Bert? No. Okay. No, just to wrap up here, I want to thank you all faculty members for bringing us those wonderful keynote lectures and giving us an insight on neuroimaging. We do all welcome you next year in our live conference in Bruges. We'll get in touch and look for a suitable date. I also want to thank the industry partners for their kind support. Thank you also King Conventions for setting up this webinar and their technical support. Also a question that popped up is that we want to make the slides of all the presentations available, but first of all, we will ask the approval of the faculty members if we can do that. So in a second mailing, we will give them available to you, all the attendees, if we have an approval from the faculty. Next slide, then I want to personally welcome you next year for our live conference in Bruges. You will mark in your agenda in September 2021. It will go on in Bruges in Belgium. We will there give you an upscale conference on neuroimaging with a Champions League-like scientific faculty as you saw today. And I promise you all attendees, it will be one of a kind. It will be fantastic. So I hope you can join us then next year. So thank you very much, everybody, for this very fluent webinar. Let's keep in touch. Check the website if you want more information about upcoming conferences. And most important, stay safe and let's keep in touch and see you later. Thank you.
Can I just make one remark, please?
Of course, Luc.
I'm not the head of the department of the University Hospital in Antwerp. So just let's make that clear. There was no coup or something like that.
Okay, that was sorry for the inconvenience, but it was not as mentioned like that. Okay, thank you, and they will close now the online webinar for the attendees.